Welcome to week three's material. This is the use of laboratory tests in the course titled Visceral Disorders and Laboratory Interpretation. Here are the learning outcomes for the next 10 hours of lecture material. Describe when to order labs. There are four main reasons. You need to know what those four main reasons are. 2. Discuss related factors to the use of labs, which would include host resistant, health benefits, costs, risks, technical and equipment quality control issues, risk management as related to the use of labs. 3. Describe when to use and how to interpret a complete blood count. 4. Describe the use of the comprehensive metabolic panel, all 17 of the items. 5. Explain how a urine analysis might contribute to making a diagnosis. And 6. Discuss the purpose of ordering other laboratory tests. This would be special tests that we will cover at the end of next week under a group called miscellaneous tests. My main source of this information is the reference text recommended by boards, NBCE, for the test plan for Part 2, General Diagnosis. It's Mosby's Manual of Diagnostic and Laboratory Tests, the 7th edition, 2022 edition. The range of the normal values is not testable. The interpretation of abnormal tests is testable, and once again, I'm asking you to focus on the keywords. So if you haven't yet downloaded the keywords, I will suggest to you download the keywords now and follow along with me. Download it in a printable format so you can make notes in the corner, and then we will continue. So I'm going to be using these lab results for comprehensive metabolic panel, complete blood count. And the reason why I am not requiring you to remember what are the reference ranges for the normal values is that when a patient goes to get some tests at the lab, and this is an example of what you get from with LabCorp, I'm not going to tell you whose lab results are these, but I do recognize them. They were done a couple of years ago. What the lab provides is not only the current result, it will give you the last result, whether it was a year ago or 6 months ago. It will tell you the date. They will give you the units in which the white blood cells are measured or the glucose is measured, and the column on the furthest right will give you the reference range. If the lab result is abnormal, as in this particular situation, they will highlight this. So look at the comprehensive metabolic panel, and the glucose is out of the normal range. There is a reddish pinkish arrow on the far left next to glucose. This is not normal. They will give you the abnormal result. It's 100. They will tell you, in case you didn't pick this up, that here is the normal range, and the normal range on the far right is between 70 and 99. This is LabCorp's range. It will print in the middle there high, in case you didn't miss the arrow on the left. This is high, and it was 100 last year, and it's 106 this year. All of the others are in normal range, except if you go down to chloride 4 from the bottom. Chloride is today 104, which is in the normal range, but last time this was done, it was 109, which was slightly out of the normal range. Okay, so this is why I'm not requiring, and therefore I'm not going to test you. Boards is not going to be that cruel to test you what's the normal values for a particular blood test. And here is our index patient, Brian Sickalot. And you will soon find out when you read about Maria Sickalot and Chloe Sickalot and Vlo Sickalot and Zoe Sickalot, and then the grandparents, they get a lot of sickness in this family. I introduced Brian to you in the first week. So this is Brian, 45-year-old mechanic, car mechanic. He is married to a 38-year-old Maria. They have three beautiful children. Chloe is 16, Zoe is 11, Flo is 5. Brian threw his back out yesterday, bending to lift a heavy box in the garage. His wife wanted to find where she put last year's Christmas decorations, and he didn't lift this heavy box in the right way. Injured his back. He's complaining today, 2 days after, with back pain. Now, remember I said there are four reasons to order labs. The first would be to confirm a suspected diagnosis. So, using the hypothetical deductive model or the algorithmic model or the traditional model, or I can recognize the pattern of polyuria, polydipsia, polyphagia as diabetes mellitus, and I suspect this patient might have diabetes mellitus, so I could order a particular test. If I thought this patient had congestive heart failure, because I recognize the pattern of symptoms, edema in both ankles, shortness of breath, worsened exertion, and waking up suddenly at night because of shortness of breath, that's called paroxysmal, sudden, nocturnal at night, dyspnea, shortness of breath. I think this is congestive heart failure. I am going to order a test that is going to help the screen for congestive heart failure. And that test happens to be the B-type natriuretic peptide. This is a peptide hormone that is produced primarily by ventricles, whether they be the right ventricle or the left or both. When they are stressed, the human heart produces this natriuretic peptide, and it's called natriuretic because it is a diuretic. The uretic part of this word tells you it's a diuretic. The natri part tells you this diuretic is aimed at excreting sodium. Na, natrium, is the chemical term for sodium. And you're looking for a result greater than 400 picograms per deciliter. If we thought this patient was diabetic because of the polyuria, polydipsia, and polyphagia illness script that we recognize the pattern, then the gold standard is fasting blood sugar, and we're looking for a fasting blood sugar level greater than 126 milligrams per deciliter. And this is one of a handful of values I am going to ask you to commit to memory. 126 milligrams per deciliter, greater than that in your fasting blood sugar, diagnostic of diabetes mellitus. The second reason to order lab results is when you don't know what the diagnosis. Now remember, there was this paper that I referred to in week one, the Hampton paper published in the mid 1970s in the British Medical Journal, where they looked at what percentage of diagnoses can be made just on a history alone. Does anybody remember what percentage was this? It was 80%. What percentage was the diagnosis made if I then had to do a physical examination, an additional 10? And 5% of the diagnoses can only be made by doing a lab test. So we don't know what the diagnosis is. We've exhausted our history, did a comprehensive, detailed physical examination, still don't know what the diagnosis, we're going to order some labs. Classic example, which we will cover in week 11, is the complaint of fatigue. There are more than 100 causes of fatigue. And hold your horses. We're not going to cover all 100. We're just going to cover 27 important causes of fatigue in week 11. In that complaint, we will say to you, when you don't know what the diagnosis is, you're going to order one, a complete blood count, possibility of anemia causing the fatigue, an infection that is hidden causing the fatigue. This is called an occult infection, or the patient might be in the early stages of leukemia, whether it be acute lymphocytic leukemia in a child, chronic lymphocytic leukemia in the elderly, and somewhere in between, adult and older adult would be acute myelogenous leukemia or chronic myelogenous leukemia. We should also order comprehensive metabolic panel just in case the liver is not functioning at 100%. We can get a clue from the comprehensive metabolic panel looking at the electrolyte imbalance if there is a renal dysfunction or a similar dysfunction in some of the endocrine glands. We're also going to order thyroid function tests just in case this is early hypo or hyperthyroidism without the classic presentation. Other tests will depend on the results of these above tests. So for example, if your comprehensive metabolic panel showed a reverse albumin globulin ratio, that should trigger some memory in your hippocampus right now. The main cause of a reverse albumin globulin ratio would be multiple myeloma. That's correct. If you suspect multiple myeloma from a reverse albumin globulin ratio, you will want to order the Bence-Jones proteins which are found in the urine. Do not expect, you will find out later. If you didn't remember my telling you this in trimester 2 when we covered this, and then repeated it in trimester 3, Bence-Jones proteins is found in the urine and it's not found in the routine urine analysis. It is a separate test that you have to order. So if you were to just order a routine urinalysis and it comes back, everything is normal, do not assume that no Bence-Jones proteins is present because they don't do the Bence-Jones protein on a routine urinalysis. The third reason you're going to order labs is for the purpose of follow-up. You're going to review the care plan. If you're dealing with an alcoholic patient and you strongly advise him, stop drinking the demon brew, and you are not sure whether he's actually compliant because the last time he visited you, you can smell the congeners of the alcohol remnants on his breath, order your comprehensive metabolic panel. Look specifically at your bilirubin, your AST, ALT, and your GGT. We're going to go into a lot more detail when we do the comprehensive metabolic panel, but what I'm looking specifically, and you can make a note of this on the line, circle GGT, because GGT is very sensitive and specific for alcohol damage to the liver. If you had a patient where the diagnosis was confirmed that this was rheumatoid arthritis and you're doing treatment with dietary manipulation, advising the use of certain anti-inflammatory supplements like curcumin or devil's claw or bromelain or whatever, and you want to monitor how effective is your treatment program, apart from getting a score from the patient. Last month, Mrs. Jones, you gave your pain scale from 0 to 10 as 8. You were in a fair amount of pain. How is your pain today? You've told me you're a lot better. And they say, oh, I'm about 3.5. You have a subjective marker. What your insurance people would prefer is having some objective evidence. And the ESR, the erythrocyte sedimentation rate, is a good tool that if you had a previous initial ESR of 45 millimeters per hour, and today it is down to 14. That is evidence of market improvement as far as the inflammatory process that accompanies this autoimmune disorder. If your patient were diabetic, you ordered your fasting blood sugar, it was 426 milligrams per deciliter, and you started a program of lose weight, cut out the sugar, and I'm going to regularly adjust you if you happen to have, and you may not know this, patients with diabetes mellitus, according to D.D. Palmer, writing in his book in the 1906 Green Book, that they tend to have a constant subluxation at around T9. According to his son B.J. Palmer, who was the person who created the Merrick chart, not Dr. Merrick, there was no Dr. Merrick. T9 vertebra is linked to T9 spinal nerve, which is linked to the pancreas. And this was based on information that he garnered from the Gray's Anatomy in 1920 to 1930 something, where they thought that one particular nerve fed into the pancreas. Further subsequent studies showed that T9 went into a larger complex of nerves known as the greater splanchnic nerve, which contained fibers from T5, 6, 7, 8, and 9. They fed into the celiac ganglia, from which nerves then went off and supplied derivatives from the foregut, including the pancreas. So part of your chiropractic care would be dietary advice, lose weight, exercise, and regular adjustments, and you want to see how effective is your treatment plan, do the HbA1c, hemoglobin, glycosylated hemoglobin, and you're looking for a value less than 7, but you want a value in between 6% and 7%. You don't want it lower than 6%, which would actually be what is found in a normal patient. You do not want that, according to the advice and recommendation from the American Diabetic Association. The third reason, or is it fourth? Yeah, I can't count. The fourth reason for ordering lab tests is for screening purposes. This is for type 1 preventative care. Men after the age of, and it varies depending on which book, 20 years ago, after I became a certain age, I'm not going to tell you my age, my PCP recommended that I do my PSA. PSA is a screening test for prostatic cancer. PSA stands for prostate specific antigen. We will find out later that in addition to prostate cancer, there are 4 other situations that could also cause an abnormal rise in your PSA, but it's a good place to start. If you're a woman and you're sexually active, the current recommendations from the American Association of Gynecologists and Obstetricians is at the age of 21 or within a couple of years of being sexually active, you're going to go for regular pap smears to pick up early changes, which left untreated might lead to cervical cancer. It's been recommended. In my days, it was over the age of 55 to start screening for colorectal cancer because of a recent bump in the incidence of colorectal cancer in younger people. The recommendation right now from the American College of Gastroenterologists is for you to beginning screening for colon cancer by doing the fecal occult blood starting at age 45. If the patient has a history, family history of heart disease, the patient has hypertension, the patient is overweight, the patient has a grayish circle on the rim of the cornea, it's called arcus senalis, which might be indicative of high cholesterol, or the patient has uh, a diagonal ear lobe crease, which might indicate a high risk of having a heart attack sometime in the future. In order to determine whether there's a risk for developing coronary artery disease, the lipid profile is a good place to start. And those are the 4 reasons for ordering lab tests. Let me go over them briefly. 1, to confirm a diagnosis. 2, to find the diagnosis if you don't know what the diagnosis is. 3, to test the efficacy of your treatment plan. And 4, to screen for specific diseases. Any questions? If there are no questions, let's look at the next lot of information that is related to laboratory test use. So the first is host resistance factors. This is related to the innate immunity. This is just revision. You've already covered this in previous classes in pathology, in immunology. The innate immunity is made up of 2 main barriers, a physical barrier and a chemical barrier. The physical barrier could be made up of the skin on the outside, mucosal membranes on the inside, and other physical structures which prevent pathogens from entering the body. The chemical barriers would be things like acid secretion in the stomach, which will destroy most organisms. Enzymes, proteolytic enzymes in the saliva will do that in some organisms. The secretion of antimicrobial peptides in the bowel that would either destroy or inhibit the growth of these pathogens in your body. The innate immunity involves cellular defenses. Phagocytic cells like macrophages and neutrophils that engulf and destroy pathogens, they are part of the cellular defense. There's also an inflammatory response. The body's immediate response to infection or injury is to produce inflammation, which involves a number of things, including increased blood flow. This is called hyperemia. Immune cell activation. There are chemicals that are released by the damaged tissue that cause neutrophils in the bloodstream to migrate across the blood capillary and get into the damaged tissue. And the release of signaling molecules like cytokines, which would include various interleukins. The adaptive variety of immunity, which is the specific, it is opposite to the innate, is also known as humoral immunity because it involves B cells, which are going to mature into plasma cells, and plasma cells are going to produce antibodies, otherwise known as immunoglobulins, that target specific pathogens and neutralizes their effect. Also involved in the adapted immunity is cell-mediated immunity. This is where your T cells, which are called NK cells that are directly aimed at killing infected cells or helping other immune cells to respond more effectively to specific threats. Any questions? Next we're going to look at is the health benefits, costs, and risks involving the use of labs. So let's look at the health benefits. The health benefits are going to be dependent on a number of things. One is diagnostic accuracy, which you need to be able to tell whether how accurately a particular test will accurately diagnose a condition, guide treatment decisions, or monitor the effectiveness of your treatment. The health benefit is related to the clinical utility or utilization. One needs to consider how these test results will impact patient care. You got to ask yourself the question, will this lead to better outcomes or improve quality of life? Or you find out that you have a terminal disease, but there was nothing you can do about this. And I'll give you an example. When I practiced in South Africa, it was in the midst of the HIV/AIDS epidemic in that country. Um, a lot of my students wanted me because of their sexual behavior. They wanted me to do their HIV testing. I was working in the Department of Family Medicine. My boss cautioned me about not doing this because he said to me, okay, Jimmy, you do the HIV tests, the ELISA comes back positive, you reflexly go to the Western blot, it comes back positive, what now? Do you have anything to offer these patients that will help them personally? And I'm going, no. Because unfortunately, at that time, even though antiretroviral drugs were available at no cost by the American government, the South African government did not believe that the human immune deficiency virus was responsible for AIDS. They thought that AIDS was due to a combination of poor nutrition and ignorance, and banned the importation of antiretroviral drugs in the country for 10 years straight. So I can do the test for you. It could come back positive. Then what? I had nothing to offer you. But here was my counter to my head of department. Prof, don't you think I have a fiduciary responsibility to let that patient know that he or she is HIV positive so that he or she could take the necessary preventative measures moving forward to prevent the spread of the virus to someone that they love and care for? He didn't have an answer for that, and therefore I continued for years testing students' blood for the presence of the virus, either the antigen or the antibody. Costs. They could be direct costs and they could be indirect costs. You need to consider the financial expense of the test itself. It comes with a cost, and sometimes if you have a good insurance, they will pay for the test. Sometimes if you don't have any insurance, you're forking out $150 for a blood test. And that fee would include the lab fee, which covers the personnel time and the use of the equipment and reagents. Indirect costs would account for the potential costs associated with follow-up tests or treatment or intervention that is prompted by the test result. Because if your test for a particular cancer, let's say we did a tumor marker for alpha fetoprotein in a 35-year-old patient and it comes back positive, I would need to then check for whether this patient has hepatocellular carcinoma, which would involve a CT scan of the abdomen. It might involve screening for hepatitis C, because hepatitis C is more commonly associated with hepatocellular carcinoma. If there is a mass, the cost will have to include biopsy, a big bore needle biopsy through the anterior abdominal mass. If there are complications such as bleeding and the patient runs into problems, the added cost onto all of that one has to take into consideration. It's not just let's do the test and that's it. Regarding the risks could be either physical or psychological. Physical risks, you have to consider the potential harm to the patient, such as discomfort while taking the sample, pain, or complications if this happens to be an invasive procedure. Give you an example. A person finds out that their uncle on their mother's side has just been diagnosed with lung cancer, and they weren't smoking at all. And you thought, I know that cancer runs in the family. Next time I visit my GP or my friendly family physician or my even friendlier chiropractor, I'm going to ask them to order a CT scan of my chest just in case I have early lung cancer. And let's say, for argument's sake, your doctor agrees with your request and orders a CT scan. The radiologist finds a 1.5 millimeter concentric mass out in the periphery of the right lung, close to the diaphragm. Can a radiologist, with this information, categorically say, nope, this will never develop into cancer? No, he can't say that, and may send you back to the PPC, or may decide on his own, I'm going to send you to a thoracic surgeon who is going to do a biopsy of the lung. And to get to that small mass out in the periphery, they have to go through the skin, through maybe the ninth intercostal space. There are problems associated with fine needle biopsy through the chest wall. The patient has to be absolutely still as you insert this relatively long needle into the lung, because if they were to take a deep breath, say ouch or sneeze, that lung will move against the sharp edge of the needle. It will tear the lung and you could develop a pneumothorax. Worse yet, if the doctor goes too far and goes through the chest wall, through the lung, and into the diaphragm, he might then injure the underlying liver on the right side, the spleen on the left side. You have an intraperitoneal bleed. You have a complication. So you need to balance the physical risks. You also need to balance the psychological risk. Assess the emotional impact of the result of the testing, waiting for the test, anxiety, waiting for the result, receiving possible unfavorable diagnoses. Are you going to tell the patient? Is the patient going to share this with their loved ones, etc., etc.? What also complicates the matter in the risks and benefits and costs is the issue of false positives and false negatives. Now, I know you've done this in your course in epidemiology and public health. False negatives and positives evaluate the likelihood of an incorrect result, which might lead or could lead to unnecessary treatment. If there's a false positive, you tell me this is cancer, I go in there, I biopsy this, turns out when they send the biopsy material off to the histopathologist, didn't have cancer. Did I have to go through that psychological trauma for the last 2 weeks? Or the test comes back negative. Yeah, I don't have this cancer. I am not HIV positive. I go celebrate, etc. And they miss the actual diagnosis. So this is costing both physical and mentally, because sometimes it would result in overdiagnosis and overtreatment. So you need to consider the risk of identifying conditions that may never cause symptoms or harm, leading to unnecessary interventions. We have a statement, a term for that, where we find an incidental lesion on a CT scan of the chest or the abdomen or the head and neck region, and it turns out to be nothing, a hamartoma. We call that in medicine an incidentaloma, a benign tumor that is found on by coincidence. Let's talk a little bit more about false positives and false negatives. False positive is defined as the situation when a test incorrectly indicates the presence of a condition or disease in a healthy patient. The causes of false positive tests would be cross reactivity. I'll give you a good example. The ELISA test for HIV is a relatively good screening tool, but not a very good uh, confirmatory diagnostic tool. So it has a very high sensitivity, but does not have a very high specificity. I had a neighbor in South Africa, in Pretoria. He was young, he was going to get married. Part of the regulations were go get yourself tested for STDs, including an HIV test. He freaked out when his HIV ELISA test came back positive. He never slept with anybody. He was a virgin. How could this be? How could he have gotten this? And I said to him, there are more than 60 causes of a false positive HIV test. You could go look this up. It could be a simple viral infection caused by the common cold or by the Epstein-Barr virus. It could be pregnancy. It could be leprosy. It could be a whole host of things. And I said to him, in 2 weeks' time, go back and have the test repeated. It's most likely to be some cross reactivity because he said to me, I had a cold 2 weeks ago. Could that have caused some cross reaction? I said, most likely. Cross reactivity, went back, had him retested, came back negative. He was clear to go and get married. It could be contamination of the sample. It was mixed with some other patient's material. There could be technical errors. We're humans, or it could be improper test calibration of the test tools. False negatives. We're going to talk about the definition and we can talk about the causes. The definition of a false negative. A false negative occurs when a test incorrectly indicates the absence of a condition or disease in a healthy patient. Causes: improper technique, timing of the test. There are a couple tests. In particular, what comes to mind is cortisol testing. Cortisol has what is known as a diurnal peak. It rises in the morning, drops in the evening. If you're suspecting a patient with moon phase having Cushing's disease or syndrome, you're going to want to order the cortisol. Because of this diurnal variation, you must consult with the lab. If this is Cushing's syndrome you're looking for, the lab will tell you, please tell the patient to come in at, I think it's 10 o'clock in the evening. If the patient was suffering from postural hypotension, darkened skin, chronic fatigue, and you're suspecting the opposite of Cushing's, you're suspecting Addison's disease, adrenal insufficiency, you need to be testing the patient early in the morning instead of late in the evening. So the timing of the test is important. Contamination again, degradation of specimens. This happens often with blood samples. If you take blood for a complete blood count and at the same time you took blood in a different tube, because it's two different tubes for the complete blood count in your comprehensive metabolic panel. If the tube for the comprehensive metabolic panel is left too long out at room temperature, the red blood cells are going to lyse. The potassium, which is confined, is the main intracellular ion, will now escape into the serum and you will have a abnormally high level of serum potassium, which may freak you out because it's 6.2 when the normal is between 3.5 and maybe 4.8 or something like that. And 6.2 is verge on any more of this and you're dead. It may be due to lysis of the blood staying at the wrong temperature with degradation of the specimen. It may be calibration errors, or it may be the lab manager forgot to order new reagents and you use old expired reagents. Now, here's a question that I want you to think on. Which is worse? A false negative test or a false positive test? Well, the answer depends on the seriousness of the disease that is involved. If the diagnosis is cancer and the test that you are going to do incorrectly says there is no cancer, then what will happen is that you will delay the diagnosis. Treatment for the cancer will be delayed and the prognosis will be poorer. This is very common in breast biopsies. You have a suspicious lesion picked up on palpation. You send the patient for further examination to a surgeon. The surgeon orders a mammogram. The mammogram comes back results inconclusive, suggests a fine needle biopsy. The fine needle biopsy is done, sent off to remember, to the cytopathologist, not the histopathologist. The cytopathologist reviews the specimen, says there are not enough granular tissue cells in here for me to make a definitive conclusion because I don't see any evidence of malignancy. No hyperchromatism, no pleomorphism, no bizarre nuclei or prominent nucleoli. If you were to briefly scan through this and you saw no evidence of malignancy, you might interpret the report to your patient, or if this is your own report you're reading, as, oh great, this is not cancer. Only to realize 3 years later when the nipple on that side with the lump that you found 3 years ago is retracted, you now have orange skin appearance over the tumor, and you have a hard, irregular lump in the anterior fold of the axilla, and you go, oops, let me go look at this. This happened with my wife's cousin a couple of years ago. She had a lump. She went to her doctor. They did a mammogram. They biopsied it. The report came back negative. I was visiting Canada at the time when my mom was transitioning from here to eternity, and she came over to visit, and she says, Uncle Jimmy, should I be worried about this lump in my left breast? And I felt a lump the size of an apricot. It was irregular. There was an indication of a node in her right axilla, and I said to her, you're going to go back to your doctor and ask for an urgent referral to a surgeon and have this looked at. It turned out to be stage 2 breast cancer. Delayed diagnosis for 3 years. You don't want this to happen. Or it could be a false positive. The lab test incorrectly says you have the disease, and I saw this once when I was studying pathology in Canada back in the 1980s. The biopsy was sent to the pathology department. The histopathologist looked at this and thought he saw pleomorphic cells, with a few of them being hypochromatic. He didn't see any bizarre nuclei or prominent nucleoli. He said, this is definitely cancer. The woman subjected herself to a radical mastectomy, left breast off, left pectoralis minor and major out, complete clearance of the axilla. And when the breast and the tumor was sent to the pathology department, 3 weeks later, they sliced this up and down and they could find no evidence of a malignancy. This not only caused anxiety, but it caused a treatment that was unnecessary for the patient, and this patient would have to live with chronic lymphedema due to the surgical removal of the axillary nodes on that one side. Any questions? The next topic in this area is technical and equipment quality control issues. These resolve around collection and labeling. You need to have proper collection techniques, use the appropriate collection tools and containers such as sterile swabs and syringes or vacutainers. Ensure an aseptic technique to avoid contamination either of your specimen or of the patient. You need to ensure that the specimens are collected at the appropriate time at peak levels for specific analytes like cortisol, whether it's Cushing's or Addison's disease. The specimens need to be labeled correctly. They have to have a barcode, a QR code, and your name. And therefore, if any of you have had lab tests done recently, before they put blood inside there, they ask you what's your name, what is your date of birth. They show you the label on the vials they're going to collect the specimens in to go, is this your name? So accurately ensure that the labels are on the specimen is correct with the correct patient information, time, date, type of specimen. Labs are now using barcode systems in order to minimize human error, but it still happens. You have to ensure that there's adequate storage and transport of the specimens at the appropriate temperatures. Some specimens need to be refrigerated, some need to be frozen, some need to be left at room temperature depending on the type of the specimen. Ensure that your transport media is appropriate to preserve the integrity of the sample. Then you have to ensure proper calibration and maintenance of the lab equipment. Make sure that your manager has organized for regular maintenance, calibration of the equipment like your centrifuges, your incubators, your analyzers to ensure accurate results. There should be quality control measures up on the wall that documents the last time I checked the auto analyzer for the complete blood count was 2 months ago. The date for the next maintenance check is in 2 weeks' time. Give us a call, etc. You need to ensure the proper handling and processing of the specimens within the recommended timeframes to prevent degradation. Follow standard protocols for centrifuging, aliquoting, and other processing steps. You also have to ensure that there is documentation of your quality control. Keep detailed records of specimen handling, including any deviation from standard procedure. You need to implement quality control procedures such as running controls with patient samples against your controls to ensure reliability of your results. Any questions? And then the last in the area of this is risk management in the use of labs. There are pre-test conditions, there are post-test conditions. The pre-test condition is related to the patient history and risk factors. Review the patient's medical record, including the family history, lifestyle, and known risk factors. This will help identify potential risks that could influence test result outcomes or your management decisions. Make sure that you have had informed consent. Patients should be informed about 1, the purpose of the test, 2, the potential risks of taking the test, and the potential benefits that could be reaped from taking the test. This would include discussing what the test results might mean, whether they are positive or negative, and how they could influence management decisions moving forward. Risk management involves, and this is repetition of a previous slide, sample collection and handling to ensure proper collection, labeling, and handling to prevent pre-analytical errors. This would include using the correct test tubes. The red top tube is for comprehensive metabolic panel. The blue top tube is for your complete blood count. The gray top tube is for your fasting blood sugar, etc., etc. Make sure that the specimens are maintained at the right appropriate temperature and you follow protocols to prevent either contamination or degradation. The patient needs to be prepared properly. You inform the patient of any pre-test preparations like fasting for 10 to 12 hours before doing a comprehensive metabolic panel, avoiding certain medications which may affect the lab results. Some of them, they say it's okay for you to take your thyroid medicine before you come to see us. You're going to have your blood taken at 8:30 in the morning on Tuesday, but you need to fast. But take your thyroid medication. The same for your diabetic medication. We don't want you running into either hyperglycemia or hypoglycemia as a result of your not taking your medication. Now, I know this is an awful lot of information. Now, I haven't highlighted, I haven't put in bold, I have not underlined, put in red, I have not said put a big fat asterisk near to this because this is important, because what I've said to you, the important bit of information from this last almost an hour bit of information is in the keywords. So the questions on this last bit of information related to lab issues, which included host resistant factors, health benefits, quality control issues, etc. Here are the 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16 key terms that I want you to be focused on. Your first examination is going to include a number of questions from this particular section. It may be diagnostic accuracy. It may be what does a false positive or false negative mean. It may have to do with documentation or with either the difference between the innate immunity and the adaptive or humoral immunity. Okay, so this is what you need to focus on. Any questions? All right, in the next 20 minutes, let's look at specific tests. Back to our patient, Brian Sicolot, and you're going to hear me mention Brian's name, and every time I mention Brian's name, I'm going to remind you. He is 45 years of age. His occupation is a car mechanic. He is married to a younger woman, Maria. She is 38 years of age. They have 3 beautiful children. And for the purposes of this discussion, Brian threw his back out, and now we're going to ask the questions. First of all, should we order any tests on Brian based on this information alone? Now, you're going to hear me repeat when we do Maria. I'm going to say to you, Maria is the 38-year-old husband of Brian and the mother of 3 children. Chloe is 16, Zoe is 11, and Flo is 5. Do you think it's important for you to remember this kind of details with each of your patients, that you remember their name, that you remember they are married and what the wife's or husband's name is, that if they have any children, you know that Chloe is about to graduate from high school. She was preparing for her prom night. Zoe is middle school, and Flo is just coming out of kindergarten going into grade 1, and she's whatever, little things, so that next time the patient comes in, so let's say it's Brian, part of the discussion is, how is Maria doing? You said to me, Maria last time was complaining of feeling tired. Did you tell her that if she continues to feel tired, she can come and have a chat with me? How is your teenage daughter, how is Zoe doing? Or, sorry, Chloe doing? Or Zoe or Flo? When you remember kinds of details like this is part and parcel of not showing you have listened to the information Brian gave you in the first encounter or collected by your front desk people, but it shows you have made an attempt to remember this and it makes you more personable. And the next time one of Brian's friends are looking for a good chiropractor to come to, guess who he is going to recommend? You. And you don't have to go through any um, a management consultancy for a forum or company to market such you can get your $1 million within the first 2 years of practice, etc. So this is Brian. Possible blood tests for Brian. Do you think if that's all the information you have, assuming there's nothing else wrong with Brian, do I need to order a complete blood count, CBC, CMP, thyroid function test, urinalysis, da da da? The answer is no. However, if Brian had any of these complaints like fever, I'm thinking fever with back pain. Remember, fever was one of the, or is one of the red flag situations in Murphy's paper. F in red flags is for fever. The significance of fever in a patient with back pain is the possibility of osteomyelitis. And therefore, I will be ordering a complete blood count. I'm looking specifically for neutrophils being increased if this were bacterial in nature, and most osteomyelitis are bacterial in nature. I'll be looking for a rise, an elevation in the white blood cell count. If Brian said to me he was having some difficulty peeing and was burning when he was peeing, associated with the fever, I'm thinking possibility of pyelonephritis. In addition to ordering the complete blood count, I'll be ordering a urinalysis, a routine urinalysis. If Brian had complained of unexplained weight loss, and by unexplained weight loss is more than 10% loss of your last weight over a year period, I'm thinking, I don't like that weight loss, that you weren't even on a diet or trying to lose weight. Possibility of bone cancer, whether it be primary or secondary. I'm ordering a comprehensive metabolic panel, which will give me a clue as to whether there's bone metastases, whether it's osteolytic in nature, whether it's primary or secondary. If Brian had a history of previous cancer, then yes, I am ordering additional tests to see whether the cancer has recurred. I know he is 45 years of age. I know that prostate cancer is uncommon in this age period. That is so for white people. It is not so for black patients. Black patients, unfortunately, have a more aggressive form of prostate cancer that occurs earlier than the 65, 70-year-old white patient. Most white patients in that age group, the elderly, are going to have a slow growing, indolent, not too concerned form of prostate cancer, unless you are like the former President Joe Biden, who had an uncommon aggressive form of prostate cancer. I'm going to order a CMP and I'm going to order the PSA to find out if it's related to prostate cancer. Possible medical causes of Brian's back pain. This is a journal article written back in 2007, published in the Cleveland Clinical Journal of Medicine. It's entitled Masquerade Medical Causes of Back Pain. If you look at some of the causes in the right box, it could be emergency situations that present like back pain, but they're not originating from the back, dissecting aortic aneurysm, going into the abdominal aorta, ruptured ectopic pregnancy, myocardial infarction, urgent situations that may require an urgent referral, not a 911 call. So your emergency situations require a 911 call. So in this breakdown that they've given us here, they've actually said top tier 911 call. Middle tier of the four, acute pancreatitis, duodenal ulcer, pyelonephritis, or visceral trauma, urgent referral to the hospital, or potentially serious conditions like gallstones, otherwise known as cholelithiasis, endometriosis, fibroids, kidney stones, PID, pregnancy, prostatitis, or urinary tract infection, which, from a chiropractic perspective, you are going to send the patient urgently off to a primary care physician for some of them and to the appropriate specialist for others. Like PID goes off to the gynecologist, nephrolithiasis goes off to the urologist, prostatitis goes off to the urologist, etc. Any questions about possible tests for Brian at this stage? Remember, if he doesn't have any fever, no history of previous cancer, no unexplained weight loss, no urinary symptoms, Brian is not having any test, including X-rays, CT scans, and MRIs. There are specific protocols that I'm sure you've learned from your radiologist, or you will learn shortly as you migrate into the clinic. No, we're not going to be ordering any special imaging on this patient because they have no red flags. If they have a red flag, then the red flag may determine I am sending this patient off for an ultrasound. Let's say the patient presented with left lumbar pain. You would have been taught in the examination of the abdomen. If this is an older person, before you adjust and look for the subluxation, have the patient in the supine position. You are going to auscultate the abdomen. You're going to auscultate the midline in the epigastric region. And if you hear a whoosh, 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 an abdominal bruit, it might be indicative of a triple A. And the appropriate test at this stage initially is sending the patient off to the radiology department for an ultrasound of the upper abdomen, and they will tell you, yes, there's a abdominal aortic aneurysm. The measurement is 3.5 centimeters, and they will probably put a recommendation repeat on an annual basis. If it gets up to a certain point, they're going to go refer this patient to a vascular surgeon because the risk of this rupturing suddenly has just escalated because it's now above 5 centimeters in diameter. I'm just calling figures. They will teach you that in radiology. All right, so let's look at specific lab tests. We're going to look at, okay, so let's begin our discussion on complete blood count. When should you order a complete blood count? There are a couple of scenarios that when you encounter clinically, CBC, complete blood count, is the way to go. One is if you suspect the patient has an anemia. You can suspect anemia from the patient's complaint of chronic fatigue or shortness of breath that is worse on exertion, or on the physical examination finding of pale mucous membranes or spoon-shaped nails, otherwise known as koilonychia. Both of these are classic for iron deficiency anemia. If you suspect this patient might have an underlying infection, like the patient has backache and he has fever, and you think, I kind of saw needle track marks in the left cubital fossa. I wonder whether this young man is abusing IV drugs, and the combination of recent back pain and a low-grade fever might mean he has an underlying osteomyelitis. If the patient has epistaxis as a child, remember the story I told you about the nurse being concerned about his recent episode of epistaxis, and you think possibility of leukemia, then it is a valid reason for ordering a complete blood count. If the patient has bleeding in the skin for whatever reason, whether it's a child or the elderly, and you suspect maybe the platelets are abnormally low, possible thrombocytopenia of whatever cause, it is a valid reason for ordering a CBC. Now that you've ordered your CBC, what are you doing with the result? Well, the lab report will contain a number. And the first number is the red blood cell count. Remember, you're not using any values unless I specifically ask you to remember, and only those that I ask you specifically to remember you could be tested on. Red blood cell count, if your RBC count is low, you have an anemia. It doesn't tell you what kind of anemia morphologically it is or what is the etiological nature of the anemia. If your red blood cell count is high, then you could be suffering from polycythemia. The lab report is also going to tell you what is the hemoglobin level. If the hemoglobin level is low, presence of an anemia, but again, doesn't tell you what kind of anemia or what causes anemia. If the hemoglobin count is high, you could be suffering from polycythemia. They would also report on the hematocrit, and the combination of these three, red blood cell count, hemoglobin levels, hematocrit, is going to tell you whether this patient is anemic or not. Because if you have an anemia, your hematocrit is going to be low. If you have polycythemia, your hematocrit is going to be high. The next, and they're usually three, but I only concentrate on two, is mean corpuscular volume, mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentration. I only do mean corpuscular volume and mean corpuscular hemoglobin concentration because they are allied to a couple of terms like microcytic, normocytic, macrocytic, or hypochromic, normochromic, or hyperchromic. So if you look at the mean corpuscular volume, which tells you the actual size of the red blood cell, if the mean corpuscular volume is low, it would be interpreted as a microcytic anemia. If the mean corpuscular volume is high, that will mean this is a macrocytic anemia. There's another word that is used at this time by some people in some books is megaloblastic. So wherever you see the word megaloblastic, think macrocytic, think large cells. When you look at the mean corpuscular hemoglobin concentration, it's a comment on the percentage of hemoglobin that is present in each cell on an average. And this usually gives you the red color. If it is palish red, it would be hypo. If it is darker red, it would be hyper. So the terms that are going to be used for the low and high would be hypochromic, and for high would be hyperchromic. Now we're going to combine these terms together. You will get a result, and I'll show you one example at the end of the discussion on complete blood count. We're going to have a clinical vignette in which I'm going to report the patient is anemic by having fatigue and pale mucous membranes, and the lab result is going to show low hemoglobin, low red blood cell count, of which you're going to go, yep, that's anemia. And then the MCV is going to be a particular comment, low, normal, or high, and the MCHC would be low, normal, or high. And you're going to have to make sense of what does this actually mean, what is the cause, and how do I dispose or of this patient. And I don't even dispose as get rid of is a medical term that I'm sending you off to the appropriate specialist, etc. Any questions so far? We're just beginning. In this slide, we're going to look at 7 different causes of anemia. So the column on the left is the etiology of the anemia, and then the columns in the middle, MCV and MCHC, will tell you the morphological type of anemia based on the size and the color. And then the 2 on the left will tell you what's likely to be happening with the total iron binding capacity and what is the specific test that would prove it is iron deficiency, lead poisoning, folic acid deficiency, etc. So let's start by looking at the first row of information. So we're looking at what are the features that are characteristic of iron deficiency. Iron deficiency is characterized by small red blood cells. So your MCV is going to be low. The word for this is microcytic. The MCHC, which talks about the color, the concentration of hemoglobin in each corpuscle on an average, red blood cell on an average. This is also low. So the term for this one is hypochromic, so the morphological type of anemia that is associated with iron deficiency is a microcytic hypochromic anemia. Your total iron binding capacity will be elevated because you have very little iron in the body, and therefore you have the capacity to take in more and store more iron. That is what your TIBC tells you, total iron binding capacity. It is elevated. The specific test, however, to confirm your patient has an iron deficiency because it has a very high specificity is the serum ferritin. If your serum ferritin is less than a specific number, you don't need to remember that is less than 20 picograms per deciliter. You just need to know it is less than normal. You have confirmation of the diagnosis that the microcytic hypochromic anemia that is causing the patient's mucous membranes to be pale and chylomicria to be present is due to iron deficiency. Lead poisoning, you will note, also causes a microcytic hypochromic anemia. The MCV in lead poisoning is going to be low. The MCH is going to be low. However, since you're not messing with the amount of iron that is available in the body to be used in the manufacture of red blood cells, your TIBC is going to be normal. The tests that you should be looking for, that when you see this in a lab report, there's basophilic stippling of red blood cells. The lab technologist is going to put a note down at the bottom on the comments or recommendation. Suggest you do a blood assay for lead, and that would be the confirmatory test. But as far as your boards are concerned, you need to remember basophilic stippling as the test. Then you have 2 conditions that clinically might look like each other, folic acid deficiency or B12 deficiency. They're going to both complain of fatigue. They're going to both have beef red tongue. One of them is going to be associated with pregnant mothers, usually the other not, more associated with strict vegans. One might be associated with neurological complications, the other one might not. So you might not be able on a clinical basis to differentiate when you see a patient with fatigue and a beefy red tongue. Is this folic acid deficiency or is this B12 deficiency? You order your complete blood count. Your complete blood count is going to show in both of these an anemia, and both of these will show an MCV that is high. So this would be a macrocytic anemia, but your MCHC is going to be normal. That would be a normochromic, so new term. Macrocytic normochromic anemia, your total iron binding capacity, since this has nothing to do with iron use, is going to be normal. And the test you're going to learn for your boards is the homocysteine test, which would be elevated in folic acid deficiency. Today, we skip the homocysteine. We go straight away and do a bioassay of folic acid vitamin B9, but for historical purposes, you need to know this for your boards. As I said, your vitamin B12 deficiency is going to show you a similar morphological pattern: macrocytic anemia, otherwise known as a megaloblastic anemia, that is normochromic. Your TIBC is going to be normal, but there's another chemical that is going to be elevated in the blood, and that would be your methylmalonic acid. Methylmalonic acid will be elevated in B12 deficiency preferentially. Alcoholism will give you a similar morphological picture like B12 and folic acid deficiency. Macrocytic, normochromic, normal TIBC, but the test you are going to be ordering is your comprehensive metabolic panel. You're going to be looking specifically at your gamma glutamyl transferase levels, and if it is elevated, then you have evidence that, yep, this is alcoholism. Hereditary spherocytosis is a condition in which it runs in families. Your red blood cells are not the normal biconcave discs that are easily maneuverable around corners and cracks and crannies in your capillaries. They would be shaped like miniature microscopic golf balls, round like spheres, hence the term spherocytosis. Osis is a condition of cells, cyto, that are round like a sphere. TIBC is going to be normal, and the test for boards would be your osmotic fragility, and I'll tell you a little bit more detail about what this osmotic fragility test involves later on in this week. And then you have what is known as the anemia of chronic disease. The anemia of chronic disease is described as normocytic because the MCV is normal, normochromic because the MCHC is normal, your TIBC is normal, and the specific test will depend on the cause of the chronic disease. And if you can think of any chronic disease, by and large, you're going to get a normocytic, normochromic anemia. Tuberculosis is chronic. Rheumatoid arthritis is chronic. Systemic lupus is chronic. Scleroderma is chronic. All of these chronic diseases are going to give you a normocytic, normochromic anemia. But having said that, that's the rule. There are often exceptions to the rule. So here are the exceptions to that last rule that says all anemias associated with chronic diseases are likely to be normocytic, normochromic. Here are the two exceptions: Crohn's disease and ulcerative colitis. Both of these, affect the bowel in the abdomen. One affects mainly the terminal ileum, which is found on the right side of the lower abdomen. The other one, ulcerative colitis, affects the colon, mainly the sigmoid colon, the rectum, and maybe the descending colon, which is primarily related to the left lower abdomen. Both of these will present with anemia. Both of them will present with diarrhea. One of them, blood in the stool, the other, no blood in the stool. And they will have a different morphological type of anemia due to the underlying pathophysiology. If you remember, Crohn's disease affects preferentially the terminal ileum. Terminal ileum is where all of your B12 is going to be absorbed, and if you've destroyed the absorptive capacity of the terminal ileum, you're going to end up with a B12 deficiency, which will give you a macrocytic normochromic anemia as opposed to normocytic normochromic anemia for chronic diseases. Ulceritis, on the other hand, left hand now, as opposed to right hand. The ulcers bleed constantly. You're going to lose blood. you're going to lose hemoglobin, you're going to lose iron in the hemoglobin, and therefore that deficiency that you get with ulcerative colitis, which is a chronic disease, is the iron deficiency variety, and iron deficiency would be characterized morphologically as microcytic hypochromic anemia. There is another index that is usually associated with complete blood count, and this one, some labs may do it. If not, you can calculate this yourself. The Metzner index is an index to determine whether your microcytic anemia is due to iron deficiency or thalassemia. We haven't talked about how to differentiate between iron deficiency and thalassemia. Both of them are going to give you a microcytic hypochromic anemia. Two different etiologies. One is a deficiency, the other is a congenital abnormality in the synthesis of hemoglobin. And the way this calculation is made is you take the mean corpuscular volume and you divide it by the red blood cell count. You're not going to be asked to do this in Boers. They will give you what the Metzner index is, or if you happen to know that this is an iron deficiency anemia, or this happens to be thalassemia major anemia, you can then infer what the value is going to be. So if the Metzner index is less than 13, you're dealing with thalassemia major. If it is greater than 16, you are dealing with iron deficiency anemia. Okay? So let's conclude this part of this discussion by giving you a typical extended multiple choice question in part 3. This is a 57-year-old overweight man who complains of fatigue for the past 6 months. He has lost some weight recently, which is good for him because he's overweight, and reported that he has passed bright red blood in the stool in the last week, and that's what freaked him out because he's been fatigued for the last 6 months, lost a little weight, didn't think anything about it because his wife said, yeah, you're looking a little better. You could lose some more weight. On the physical examination, his mucous membranes are pale. Lab results show a low red blood cell count, a low hemoglobin, a low mean corpuscular volume, a low mean corpuscular hemoglobin concentration. Which two statements regarding this patient are correct? You need to select two. So you look at all of this, and you're going to look at the first statement and see whether this first statement is correct or not. First statement says he has a microcytic hypochromic anemia. What do you base the diagnosis of a microcytic hypochromic anemia on? Low red blood cell count, low hemoglobin, so that's the anemia part, low MCV, so that's the microcytic part, low MCHC, that's the hypochromic part. Yep, A is correct. Let's look at the next statement. Vitamin B12 deficiency is the diagnosis. You go, no. Vitamin B12 deficiency is going to give you macrocytic normochromic anemia. So B is wrong. C, methylmalonic acids will be elevated. If you remember from the last two previous slides, methylmalonic acid elevation is diagnostic of B12 deficiency. And if we've ruled out that this is not a B12 deficiency because of the lab results, then C is also wrong. The Metzner index will be less than 13. Only two things you use the Metzner index for. Less than 13, thalassemia is the cause of the anemia. Greater than 16, iron deficiency. So Metzner index less than 13, which indicates thalassemia is the diagnosis. That is not true. This is not thalassemia. And the last statement, he should be screened for colon cancer. Overweight, and you know that obesity carries the risk of increase in a number of cancers. The cancers have gone up to 13 now. I think when you did cancers in general in um, trimester 2 in general pathology, your teacher would have told you there are currently 12 cancers. That was a year ago. Couple months ago, they've added a 13th cancer as definitively linked with obesity. So, obesity, trigger for a thought that this could be cancer. Recent weight loss, didn't say unexplained, didn't tell you that he was trying to lose weight, so you're going to assume this weight loss is significant, and you think unexplained weight loss, possible cancer, and then he reports passing bright red blood in the stool. That's a red flag situation. When you have blood coming out from where it should not come out, from your nose, in your spit, in your sputum, in your stool, in your urine, through your skin, through your ear hole, any orifice, it's abnormal. It tells you that maybe the problem that is causing the unexplained weight loss is related to the GI tract. And therefore, he should be screened for colon cancer. This person ended up having stage 2 colon cancer, which is still treatable, but you would have wanted not for this to develop. Okay. Any questions? If not, let's look at the other parameters that are reported in your complete blood count. In the lab report, you're going to get a report on the white blood cell count. If there's a normal 3.5 to 5.5 thousand, if it is less than a certain amount, you're going to go, okay, leukopenia is present. Leukopenia is the medical word for low white blood cell count. Leuko to do with white, emia to do with blood, penia to do with poor in the blood. So leukopenia, decreased white blood cell count. Two conditions I want you to remember: HIV/AIDS, one on sarcoidosis. I need you to put an asterisk next to sarcoidosis because it's linked to another abnormal finding when we come to do tomorrow your comprehensive metabolic panel. And I need you to remember that sarcoidosis on one hand in the complete blood count shows a low white blood cell count. And when you do the comprehensive metabolic panel, I will tell you and remind you tomorrow that it's associated, interestingly enough, with a high calcium level. And this is important to remember from a board's perspective. If your white blood cell count is high, and the word we use for that is leukocytosis. Os is a condition, leuko to do with white, cyto to do with cells. The term leukocytosis means there is an increase in your white blood cell count. It could be due to two things: infection or leukemia. How do you tell from the blood report that this is leukemia, which is potentially fatal? Not saying that you can't have a fatal infection. You could have that too. You're going to look for the amount of white blood cells in a cubic millimeter of blood. And if it is greater than 25,000, that's classic for leukemia. It's usually 50, 75,000 for various forms of leukemia, but the cutoff point for you to start thinking, I don't like this, is 25,000. Less than 25,000 but greater than 11,000, you are in the range for an infection. And the higher your leukocytosis is the more serious the infection is. If it is now less than 25,000, so you're in the ballpark of this is an infection, your lab report is going to tell you about the neutrophil count. not going to test you what's the normal neutrophil count, so you don't need to go back to let my engine blow 60-30 A20 to remember this. You're not going to get blood values in parts 2 and 3 for reasons that I've explained already before, but you're going to get either the term high neutrophil count or the alternative name. And if it is not in your keywords and you're not familiar with this alternative name, I would strongly recommend that you write this down somewhere, append this to modify your keywords. The term that means exactly high neutrophils, the word is neutrophilia, and that may be seen in acute infection or may be seen in bacterial infections. If your lymphocytes are elevated, then the term you're going to use for high lymphocytes is not lymphophilia, it is lymphocytosis. Osis, a condition, lymphocytes, a condition in which your lymphocytes, which is one of the 5 types of white blood cells. Remember, there are 3 granulocytes, there are 2 agranulocytes. Your 2 agranulocytes are lymphocytes and monocytes. Your 3 granulocytes are neutrophils, basophils, and eosinophils. If you have a lymphocytosis, aka high lymphocytic count, you're dealing with a chronic inflammatory disease or viral infection. High eosinophils, otherwise known as eosinophilia, seen in parasitic infections. Basophilia, high basophilic count would be seen in allergic reactions. And if your monocytes are high, and once again, a high monocytic population is known as monocytosis, you get this also in some chronic infections. Any questions? If there are no questions, let's finish this up, our discussion on the complete blood count, by looking at platelets. Platelets are derived from fragmented larger cells known as megakaryocytes, and they are essential in the coagulation or clotting cascade. When your platelets are low, the term for this is thrombocytopenia. Thrombo to do with clotting, cyto to do with cells, penia to do with decrease in the blood. There are a number of causes of thrombocytopenia. When we do fatigue or skin rashes, we will talk about them later. But just to remind you that here are a couple of important causes of thrombocytopenia. The first is called immune thrombocytopenic purpura. Immune cells, obviously. We know it's an autoimmune disorder, thrombocytopenia. As I explained, there is a low amount of platelets in the blood, and purpura means there's a reddish purple rash in the skin due to bleeding in the skin. And depending on whether it's very small, the term for that would be petechiae, or very large bruise-like lesions, that would be ecchymoses. So immune thrombocytopenia purpura is characterized laboratory-wise by 1, obviously low platelets. Your red blood cell count would be normal, so there's no anemia. Your white blood cell count is also going to be normal. There's no leukemia, leukocytosis, or leukopenia. The next cause of a low platelet count would be acute leukemia, where this is acute lymphocytic or acute myelocytic leukemia. Again, the platelet count is going to be low. However, the white blood cell count is going to be extremely high. Remember the value that I talked about, greater than 25,000 per cubic millimeter. And then lastly, so there are 3 causes of low platelet count or thrombocytopenia would be a rare condition known as aplastic anemia. Aplastic anemia could be drug induced, it could be caused by viruses, or could be caused by whole body radiation if you're treating widespread bone metastases. In aplastic anemia, not only are the thrombocyte population affected, but your red blood cell production is affected and your white blood cell production is affected. So you're going to have low platelets, low red blood cell count, and low white blood cell count. Please make sure you know the difference between these three causes of thrombocytopenia, because you are going to get at least one question in your first examination in a couple of weeks' time. Are there any questions? Okay, we'll spend the rest of the hour looking at comprehensive metabolic panel. When exactly should a comprehensive metabolic panel or CMP be ordered? One, if you suspect a patient of having kidney disease, either oliguria, small amounts of urine, or presenting with edema. Two, if you suspect a patient of having liver disease, jaundice, and or edema. Three, if you think that the patient, because of the moon phase or the postural hypertension or the darkening skin, may have an endocrine problem, presenting with fatigue, a CMP is a good place to start. And the fourth of these reasons is if you suspect bone disease, especially bone disease related to cancer, whether it be primary or metastatic. If the patient complains of bone pain that is worse at night, you should think of the possibility of some bone problem. Now, the comprehensive metabolic panel is conveniently divided into approximately half. The top half of this is called urea and electrolytes, and it includes glucose, BUN, creatinine, sodium, potassium, chloride, carbon dioxide, calcium. If you were to draw a line there at calcium, that would be the U and E, urea and electrolytes, and below that would be tests or results that are clumped in a group called liver function tests. The liver has more than a dozen functions, and one of the functions is to take amino acids absorbed from the gut via the portal vein and combine them in various forms to form proteins, particularly albumin and globulin. The liver is also responsible for handling bilirubin. So you're going to get a result that says here's the total bilirubin. They may break this down into direct or indirect, and then there are other enzymes, alkaline phosphatase, AST, ALT, and GGT, that would indicate that possibly the liver cells, the hepatocytes, are being damaged. So the first in the lab report is your fasting blood sugar. Your fasting blood sugar, according to this lab, which is LabCorp, says it's between 65 and 99 milligrams per deciliter. If it is less than 70, or in this case 65, it all depends on the lab report, then you are suffering from hypoglycemia, which could be drug induced. Common drugs would be drugs used to lower your blood sugar in diabetes mellitus, or you have a rare condition in which there's a benign tumor in the pancreas called an insulinoma, and this benign tumor of the pancreas of the beta islet cells of Langerhans are going to be secreting insulin in an episodic fashion, and every time the insulin production goes up, your blood sugar goes down, and you're going to get something called Whipple's triad, where the patient presents with symptoms of hypoglycemia, nervousness, tachycardia, sweating, confusion. That's the first of Whipple's triad. Two, you will document that the fasting blood sugar, or the sugar at the time of this episode, is less than 70 milligrams per deciliter. And the third of Whipple's triad is that if you have the patient drink highly sweetened juices over the next 3 to 5 minutes, then the hypoglycemic symptoms will be corrected. And that is Whipple's triad, that is characteristic of insulinoma. If your fasting blood sugar is above 126 milligrams per deciliter, then you have the diagnosis of diabetes mellitus. You could also have this elevation seen also in Cushing's syndrome, because in Cushing's syndrome there's an excess production of glucocorticoids. Glucocorticoids or steroids are stress hormones, and one of the functions of stress hormones is to get the skeletal muscle and your liver to release glucose from stored glycogen in order to prepare you either for flight or fight, and this will cause a temporary increase in your blood sugar. Next would be BUN. BUN stands for blood urea nitrogen. This is a measure of how much urea the liver is producing. Remember, when proteins are broken down into amino acids, and amino acids are degraded by deamination, ammonia is released. Ammonia is toxic to the body. Ammonia is combined with carbon dioxide, and it goes into what is known as the urea cycle. Out of the bottom of that cycle, urea and water comes out. Urea is then put into the blood, passed through the kidney, and therefore could be used, if elevated, as an indication is there kidney function or something else wrong with the patient. So if you have a high BUN, blood urea nitrogen, it could be one of three things: dehydration, burns, which will cause dehydration, or you are in renal failure. It doesn't say whether this is acute renal failure or chronic. Your kidneys are not doing the work it was intended to do. If your creatinine is high, now creatinine comes out from skeletal muscle. If your creatinine levels are high, it could be due to rhabdomyolysis, big word for muscle damage, skeletal muscle damage, or it could be seen again in renal failure. So if these two are individually elevated, these are the causes. When both of them are elevated and your BUN creatinine ratio is greater than 25:1, then the combination of your BUN and your creatinine is indicative of renal failure. Now, you may encounter two additional words in boards to do with elevation of your blood urea nitrogen. One is azotemia. Azo is the Greek word for nitrogen. Emia is to do with the blood. So azotemia is referring to a blood result in which you have an elevation of your blood urea nitrogen and your creatinine levels. Usually this is asymptomatic until the blood urea nitrogen builds up to toxic levels in the blood, and then you're going to have uremia, which is a clinical diagnosis. Uremia, urea, mia, combined together, it is excess urea in the blood, emia. Can be suspected in a patient in which there's fatigue, there's nausea, there's vomiting. On examination of the heart, you may hear a cement mixer crunching like sound when you auscultate over the precordium, which would be indicative of pericarditis, because one of the manifestations, pathological manifestations of increased blood urea nitrogen is it accumulates in the pericardial sac and then irritates the pericardium on the inside and causes a pericarditis. And then you can also, because of the accumulation of other toxic wastes in the body related to blood urea nitrogen, you're going to have this coarse flapping tremor known as asterixis. You're going to ask the patient to stick their hands out straight in front and then extend the wrists rapidly. And when they do that, the wrist will flex, and you say to them, no, keep the fingers up. And as they attempt to keep the fingers up, the reflex pulls it down, and they have this coarse bird wing flapping kind of tremor known as asterixis. So uremia is a clinical presentation that will then be backed up by evidence of elevation of your blood urea nitrogen and your creatinine. Any questions? Now let's look at some of the electrolytes. We're not going to look at all of them. We're going to look at a handful of them because this is what boards concentrates on. So we're going to look on at sodium. Sodium is the main extracellular electrolyte or ion. It is higher in the outside of the cell extracellular environment as opposed to intracellular environment. If your sodium is low, and the term that is used to indicate low sodium is hypo, low natremia, emia to do with blood, natri or natrium, from which we get Na, which is the chemical symbol for sodium. The combination of hypo, natri, emia means low sodium in the blood. This is seen in Addison's disease, which is adrenal insufficiency. If the sodium level is going in the opposite direction, higher than normal, that is known as hypernatremia. There are two main conditions that are going to be associated with this. One, Conn's disease, otherwise known as hyperaldosteronism. And aldosterone, if you remember, is a hormone, a steroid hormone that is produced by the zona glomerulosa of the adrenal cortex. It acts on the principal cells in the distal convoluted tubule primarily, and it causes reabsorption of sodium from the urine, and that excess sodium pulled out from the urine goes into the blood, causing the blood to have an exceedingly high level of sodium. Cushing syndrome can also do that. Glucocorticoids that are the result that cause the Cushing's manifestation also has a slight mineralocorticoid effect. We're going to look at potassium. Potassium is the predominant intracellular ion, and remember, in order to maintain an electrolyte balance, if your sodium goes up, your potassium is going to go down. If your sodium goes down, your potassium is going to go up. So if you learn only what causes hyponatremia and hypernatremia, you should be able to work out without having to commit this to memory that if you have hyponatremia, you should have hyperkalemia, and if you have hypernatremia, you should have hypokalemia. So let's start with hypokalemia, low hypoemia in the blood, kalium. K is the symbol for potassium. Hypokalemia is seen in Conn's disease, in which that is associated with hypernatremia. The opposite, hyperkalemia, is going to be associated with hyponatremia, and the most common cause of hyponatremia pathologically is Addison's disease. Next, we're going to look at carbon dioxide. Now, carbon dioxide is going to be carried by the blood in three forms, either dissolved either in combination with hemoglobin in a form known as carbamino hemoglobin, or in combination with water to form bicarbonate. When you have an elevation of your CO2 in the blood, we are measuring the bicarbonate levels indirectly, and elevated CO2 in the blood is known as hypercapnia. And the three main common causes of hypercapnia or carbon dioxide retention in the blood is congestive heart failure, chronic bronchitis, and pneumonia. Calcium. The majority of your calcium is found in storage in your bone. 99.9% of calcium is in the bone. The remainder 1% is in the blood. Some of it is ionized, some of it is unionized. If your calcium levels in the blood are low, the term we use is hypo, emia, blood calci, to do with calcium, low calcium in the blood. And the most common cause of hypocalcemia is hypothyroidism, and the most common cause of hypothyroidism is accidental removal of all four parathyroid glands when doing a total thyroidectomy for cancer or perhaps resistant to medical treatment Graves' disease. Hypercalcemia, the most common cause is hyperparathyroidism, and the most common cause of hyperparathyroidism is a benign tumor in one of the four parathyroid glands. Second most common cause of hypercalcemia is bone metastases, especially the lytic variety of bone metastases. Third most common, multiple myeloma, which is a primary bone malignancy. Fourth is sarcoidosis, and I want you to make a note of hypercalcemia and sarcoidosis. I need you to put an asterisk next to sarcoidosis. And remember, the last time I had you put an asterisk next to sarcoidosis was when we were looking at the white blood cell count. And sarcoidosis is one of a handful of causes of low white blood cell count, otherwise known as leukopenia. Because you could very well get a question on, remember this is a course that concentrates on lab diagnosis, which is the most common cause of the combination of leukopenia, in brackets, low white blood cell count, and hypercalcemia. And the answer I would like you to remember and give me then, if you get asked this question in an exam here or in boards, is sarcoidosis. Only sarcoidosis has that unique leukopenia hypercalcemia combination. And then the next most common cause of hypercalcemia would be vitamin D toxicity. Does anybody remember any of the clinical manifestations of hypercalcemia that you learned in general pathology or systemic pathology when you covered musculoskeletal disorders? No? There's a mnemonic, and if I'm sure I start this off, stones, yeah, there you are. Stones, bones, groans, and moans. In an attempt to get rid of some of the excess calcium in the blood, the body uses the kidney to excrete this. Calcium stones could be as a result of that, and they present with effects of pieces of the stone passing through the urinary system, causing ureteric colic. Where is this calcium coming in order to cause a rise in the serum calcium? It is coming out from the bone. There might be damage to the bone. There might be increased osteoclastic activity, which clears away bone. And if you have bone disease or clearing away of the bone due to excess parathyroid hormone, then the bone is going to become porous, it's going to become weak. You might suffer pathological fractures, which will then present as bone pain, which is worse at night. Stones, bones, groans. Hypercalcemia, if you remember, triggers the G cells in the stomach to produce gastrin. Gastrin is a endocrine hormone produced by the gut. Gastrin goes and stimulates the nearby parietal cells. The parietal cell stimulation is going to cause production of increased hydrochloric acid, which is now going to cause peptic ulcers in the stomach or the duodenum, and therefore the patient is going to groan about epigastric pain due to peptic ulcer formation. And then the last on the stones, groans, moans, uh, what's it? Stones, bones, groans, and moans. Moans is for depression. Not only is the patient psychologically depressed, but the conduction of nerve impulses, and you need to remember this, the conduction of nerve impulses in the presence of excess calcium in the blood is delayed. So hypercalcemia reduces the speed of the nerve conduction, ends up with muscle weakness and fatigue and mental depression. Next, we're going to look at the total protein. So we're finished with the urea and electrolyte part of the comprehensive metabolic panel, and now we're going to look specifically at the liver function part of the metabolic panel. Total proteins, and this is a combination of your albumin and your globulins. If your total proteins are low, the term that is going to be used for this is hypoproteinemia. Hypo means low, protein means protein, and emia is in the blood. Hypoproteinemia. Causes of hypoproteinemia could be one, chronic liver damage or dysfunction where the liver is not able to maintain the amount of proteins the body needs. So cirrhosis is a good example. Malnutrition in the diet. The child is not eating enough protein-based material in order to sustain the production of albumin and globulin and other important proteins products in the blood like immunoglobulins, and therefore this is going to cause hypoproteinemia. Nephrotic syndrome, if you remember, is a problem with the kidney, specifically with the basement membrane. If you damage the basement membrane, which is negatively charged, then the proteins, particularly albumin, which is also negatively charged, will then leak out through this porous, damaged basement membrane. You're going to lose more than 3.5 grams of protein in the urine in a 24-hour period, and this will then result in a drop in the protein in the blood, hypoproteinemia. Then you're going to look at labs will then tell you what the albumin and globulin ratio is. It's usually 2 to 1. And the only thing you need to remember is a reverse in the albumin globulin ratio. It's no longer 2 to 1. Globulin is more abundant than albumin, and that is called a 1 to 2 ratio. There are 3 causes of a reverse albumin globulin ratio. The first and most important for you to remember from a board's perspective is multiple myeloma. Because if you did a comprehensive metabolic panel in a patient with nocturnal bone pain that is unrelieved by nonsteroidal anti-inflammatory agents, and you have an increase in your total proteins and a reverse albumin globulin ratio, then you need to suspect multiple myeloma and then order Bence-Jones proteins in the urine. Nephrotic syndrome is another cause of a reverse albumin globulin ratio, and so is cirrhosis. And even if you have severe malnutrition in the form of protein, calorie malnutrition, kwashiorkor could also cause a reverse albumin globulin ratio. Any questions? Next, we're going to look at the tests that are commonly referred to as the liver function tests. Bilirubin is one. Bilirubin, the role of the liver in bilirubin is to take unconjugated bilirubin produced by the spleen, carried by albumin via the portal vein to the liver. It then undergoes conjugation inside the hepatocytes. Unconjugated, insoluble in water bilirubin is married to glucuronic acid. The combination now forms direct or conjugated bilirubin, and then that is passed out through the common bile duct to get into the bowel and then continue its metabolism. If your total bilirubin is elevated, it may be primarily elevated in the indirect variety. And remember, indirect unconjugated bilirubin is coming out from the spleen. And if you have excess indirect unconjugated bilirubin in your blood, it speaks of pathology before it gets to the liver. This is called prehepatic jaundice. The majority of the causes of prehepatic jaundice is either excess breakdown of abnormal red blood cells or another form of hemolytic anemia. If just the direct or conjugated bilirubin is raised, then this speaks of posthepatic jaundice. And if both of them are raised, both the direct and the indirect, the unconjugated and the conjugated, then the problem is inside the liver, intrahepatic. We're going to go through this in a little more detail shortly, and then when we do abdominal pain presenting with jaundice, we're going to pick up 3 out of the 6 diseases that I want you to remember at this particular stage and repeat it again. Okay, so we're going to spend some time on the physiology of bilirubin so that you can understand the pathophysiology of jaundice, so that you can understand the clinical presentation of the 3 varieties of jaundice. We're going to pick this up again when we do abdominal pain associated with jaundice, and we will review this and cover 3 out of the 6 diseases that are going to be mentioned in related to this slide and to bilirubin. We're going to look first of all to the diagram in the middle of this slide. And we're going to see that the metabolism of bilirubin is going to start off in the spleen, where old red blood cells or deformed red blood cells, as in sickle cell disease or hereditary spherocytosis, the red blood cells are going to go to the spleen. It's going to pass through the red pulp. It's going to be destroyed by the macrophages in the red pulp, and from that breaking down, lysis of red blood cells, hemoglobin is going to be released. From hemoglobin, heme is going to be released. From heme, biliverdin is going to be produced, and biliverdin is immediately converted into bilirubin. Now, this bilirubin has 2 names. One is called indirect, the other is called unconjugated. From a physiological perspective, I would prefer to use the term unconjugated, because when it goes to the liver for the next phase, it's going to be conjugated. However, your lab people don't use the word conjugated or unconjugated. They use the words direct or indirect. So indirect bilirubin, in parentheses, unconjugated, has a particular solubility property which you need to remember. That unconjugated indirect bilirubin is insoluble in water. Indirect bilirubin is insoluble in water. And if you have a patient with excess bilirubin, clinically manifesting by the skin is yellow, the sclera is yellow, but the urine is normal, it tells you immediately where exactly the pathology is occurring. It's occurring in the phase known as the prehepatic phase, the phase before it goes to the liver. Okay, so let's pick this up from indirect bilirubin or unconjugated bilirubin being produced by the spleen, passed into the splenic vein, which is going to then join on with the superior mesenteric vein to become the portal vein, which empties this unconjugated, indirect, insoluble in water bilirubin into the liver. We now go to the second phase, which is the phase that occurs inside the liver, otherwise known as the intrahepatic phase. Here, indirect bilirubin is going to be married to conjugated with a product known as glucuronide. And when glucuronide is attached to insoluble indirect bilirubin unconjugated, then the bilirubin changes its nature. Just like in a marriage, the woman might change her last name. And this now direct or conjugated bilirubin changes its solubility. It is now soluble in water, and you need to be able to remember this distinction. That direct bilirubin is then passed through the common hepatic duct into the cystic duct, stored, concentrated in the gallbladder, and in the presence of fat in the duodenum and the upper part of the small bowel releases cholecystokinin, CCK, from the eye cells, which will then cause contraction of the smooth muscle in the gallbladder, relaxation of the smooth muscle in the sphincter of Oddi, and direct conjugated bilirubin is going to enter the second part of the duodenum. As it passes through the small bowel, that conjugated, soluble in water bilirubin is broken down by bacteria into a compound known as urobilinogen. Some of that urobilinogen is absorbed back into the blood. Some of that urobilinogen that is absorbed into the blood is going to go back to the liver. And this is known, that circulation from the gut to the liver is called the enterogut hepatic circulation. And that urobilinogen goes back and helps the liver to produce bile salts, which is an essential component of the bile that contains bilirubin. Some of the absorbed urobilinogen in the blood will go to the kidney. And then when that urobilinogen in the kidney passes out into the urine, it is oxidized to give you a yellow pigment known as urobilin, which will then color the urine slight yellow. The rest of the urobilinogen that is not reabsorbed into the bloodstream, taken back to the liver or the kidney, remains in the stool, further broken down by bacteria, changes its name from urobilinogen to stercobilinogen, and when stercobilinogen is oxidized to form stercobilin, it then passes out in the stool and colors the stool brown. So the normal scenario at the end of all of this is you have slightly yellow urine and brown colored stool. Now let's look on the column on the left. If you have excess bilirubin, that is going to be called jaundice. You should have learned another word for jaundice. Does anybody remember? I'll give you a clue. It begins with the letter I. Yes. The alternative word for jaundice is icterus. One word is Greek in origin, the other word is Latin in origin. So if you ever see a clinical scenario in parts 3 or parts 4, and you see the description that the patient has icteric sclera, they're actually saying the sclera is yellow and this patient has jaundice. So jaundice is defined as an excess accumulation of bilirubin in the body, and it manifests in the sclera and in the skin. Now, if you look at the categories, you're going to find that we're going to divide these 6 diseases that cause jaundice into 3 groups. One group is related to problems in the spleen or before it gets to the liver. One group is related to after it gets into the liver. And then the third group is after it passes out from the liver into the bowel. So we're going to look at 2 possible causes of prehepatic jaundice. One is sickle cell disease. The other is hereditary spherocytosis. Both of these, there's a problem with the cell, the red blood cell, and they're prematurely destroyed. And when they're prematurely destroyed, jaundice will occur. There would be discoloration, yellow discoloration of the skin and sclera. However, if you go straight across to the right side, the right column, you're going to find out that in prehepatic jaundice, the urine is normal in color, normal, slight yellow tinge due to the presence of urobilin and not due to an excess amount of bilirubin, because the type of bilirubin that is produced in excess in prehepatic jaundice is unconjugated, indirect, insoluble in water. Okay, let's look at the next layer at which jaundice could occur. It could be due to problems in the liver. The 2 common causes we will talk about later in this course will be viral hepatitis and cirrhosis. In both of these, the hepatocytes are not functioning properly. The patient is not able to, one, conjugate bilirubin, or when it conjugates the bilirubin, it's not able to excrete the bilirubin from the hepatocytes into the intrahepatic biliary part of the tree. And then the last is posthepatic. This happens is due to problems after the bilirubin leaves the liver and the gallbladder. And the 2 conditions we're going to talk about are stone in the common bile duct and carcinoma of the head of the pancreas. Stone in the common bile duct would block the passage of all bilirubin from the gallbladder and the liver, so you'll get no bilirubin in the bowel, and therefore the bacteria has nothing to act on in order to produce urobilinogen. In carcinoma, the head of the pancreas, and this is the most common site of cancer in the pancreas. 65% of all pancreatic cancers occur in the region of the head of the pancreas, through which the common bile duct passes. As the cancer enlarges, it compresses the common bile duct from the outside. So inside or intrinsic obstruction of the common bile duct is caused by stone in the common bile duct. Outside or extrinsic compression of the common bile duct is caused by carcinoma of the head of the pancreas. Because no bilirubin is entering the bowel, there's going to be no urobilinogen in the urine. The stool, instead of being normally brown, would lose its brown color eventually to give you a clay-colored stool. In both, and we're going to look at the column on the right again, in both intrahepatic and posthepatic jaundice, the urine is going to look green. But only in posthepatic jaundice, there will be no urobilinogen. Now, if you understand the detail that I just shared with you, you should be able to, with 3 questions, come up with which of these 6 causes is actually the cause of a patient with jaundice. So, with just 3 questions, remember we said in the first week, 80% of all diagnoses can be made on a thorough history. 10% we need to add the physical examination findings. 5% we need to add labs on top of that, and the remaining 5% we don't know. The word I use, is that we are idiots about the pathology, idiopathic. So the first of these 3 questions is, what is the color of your stool? If the patient says it's brown, go to the next question. And I'm hoping your patient doesn't treat you like um, one of my first patients. I took a history when I was studying medicine in Jamaica many years ago, where I asked him, "What's the color of your stool?" He said to me, um, "More recently, it is blue." And I looked at him, blue, and I said, "And before it became blue, because I'm going through my head, and my professor never talked about blue stool." He said it was red. I'm going, "Oh my dear." And before that, he said it was white. And I looked at him and I'm going, "So your stool went from white, like the wall in the hospital?" He says, "Yes, doc." To red? "Yes, doc." And then to blue? "Yes, doc." And he noticed my puzzled look, and then he starts to laugh. And I said, "Mr. Jackson, why are you laughing?" He says, "Doc, that's the color of my stool that I sit on in the kitchen. It was first white. The wife wanted it painted red, so I painted it red. And 6 months ago, she said she doesn't like, she's going to change the curtains. She wants it to be blue." He says, "Doc, if you want to ask me what's the color of my shit, why don't you ask me that?" I said, "Okay, Mr. Jackson, what's the color of your shit?" And he says, "It's brown." Okay, so if it is brown, that is normal color. If the color is not brown and described as pale or clay colored, the second question, so this is the second of three questions, would be, is there any pain? If the patient says there is pain, then the answer is this is going to be stone in the common bile duct causing posthepatic jaundice. If the patient with a clay-colored stool with jaundice has no pain, the diagnosis is carcinoma of the head of the pancreas. It is that easy to differentiate between the two. If in answer to the first question, what's the color of your stool? And it says normal, you then go to the next question, which is, what's the color of your urine? If the patient says, my urine is normal color, but you know the patient has jaundice and you know it's not post-hepatic jaundice because the stool is colored, you ask the question, is there any pain? And if there is pain, it's likely to be sickle cell disease. The other clue you're going to have is that it's most likely to be a young black child. If the patient is jaundice, not African American, and there is no pain, but there's yellow sclera and yellow skin with normal urine and normal stool, hereditary spherocytosis, or one of the more uncommon causes of hemolytic anemia that you learned previously, which would be pyruvate kinase deficiency or glucose 6 phosphate dehydrogenase deficiency, otherwise known as favism, when it gets worse when they eat fava beans. If the answer to the question, what's the color of your urine, is green, then you go to the third question because you know if the urine is green but the stool is brown, then this has to be obviously intrahepatic jaundice. And then you sort out whether this is hepatitis or cirrhosis by asking the question we have asked before. Do you have any pain? If there is pain, this is hepatitis, acute inflammation of the liver, whether it be drug-induced or viral-induced, or alcohol abuse can cause hepatitis. If it is painful when you palpate the right upper quadrant, you're dealing with hepatitis. If there's no pain, you're dealing with cirrhosis. So if you look at these three questions, you can, as I said, depending on the answer to the question, you can sort out which one of these six conditions it is most likely to do with. As I said before, we're going to repeat half of what we've just gone over when we do abdominal pain in week 7, I think, of the trimester. But we're only going to be concentrating on 3 out of the 6 causes of jaundice. And this is because we'll be discussing abdominal pain with jaundice. So we'll be ruling out stone in the common bile duct, we will be ruling out sickle cell disease, and we will be ruling out hepatitis. Next in the comprehensive metabolic, and you see why this is called a comprehensive metabolic. Some labs have 14 tests, some labs have 17 tests, and depending on the lab, they may order a K14 or a K17, depending on the number of tests are in the comprehensive metabolic panel. We're going to look at specific liver enzymes so that when you damage the hepatocyte, enzymes that are normally in there to help in the functioning of what the liver does, then those enzymes are going to be released into the bloodstream and going to be elevated in the blood. It's going to be picked up in the comprehensive metabolic panel. One of those tests is the AST. AST stands for aspartate aminotransferase. This is indicative mainly of hepatic damage. If your ALT, otherwise known as alanine aminotransferase, is also elevated, it's going to be hepatic damage. You can look at the combination, the ratio of your AST to ALT. If your AST is higher than your ALT, both of them are elevated, but the aspartate aminotransferase is 4 times elevated compared to just 1.5 times elevated of your alanine aminotransferase. Then it is indicative of alcohol liver damage. If you were suspecting that the jaundice was due to alcohol damage to the liver, then look specifically at the next enzyme that is released specifically when alcohol is the trigger of the hepatic dysfunction. This is called GGT, and the GGT stands for gamma glutamyl transferase. It's a good marker if you are counseling one of your patients who is fatigued, mildly jaundiced, and you do the test and it comes back hepatitis, possibly alcohol in nature, and you're seeing him every month, and the last time you see him, you can smell alcohol on his breath, and you say to him, I hope you're not drinking any. Oh, no, no, doc, I've sworn off of the booze. You can easily order not the full comprehensive metabolic panel, just order the GGT and look for evidence. So when he comes back next time, you can have a serious chat with him. There is another enzyme that not only is produced by the liver when it's traumatized or dysfunctional, but also can be released if there is damage to the bone. How do you tell whether your raised alkaline phosphatase is due to bone damage or liver damage? If this were due to bone damage, your calcium might be elevated, but your serum, your albumin globulin ratio will be normal. Also, if you have, and if that is so, then it's bone metastases. Your hypercalcemia with your normal albumin globulin ratio could also be raised in a healing bone fracture. When you have a raised serum calcium but a reverse albumin globulin ratio, then you should consider that the problem is not only bone related, but it's specifically because of the reverse albumin globulin ratio, it would be multiple myeloma. Now, if your alkaline phosphatase is raised, then you might get a scenario where they give you the results of a patient with jaundice, and they say here is the patient is suffering from, and they're not going to give you bilirubin is 3.2 milligrams per deciliter, and that put in parenthesis the normal value is between zero point 0.1 and 1.2. They're going to stay specifically with the following lab results: hyperbil hyperbil hyperbilirubinemia, hyper excess bilirubin, emia in the blood. So the patient's lab results shows hyperbilirubinemia, hypercalcemia. And the moment they give you that, you're going, wait a minute, something is wrong with the liver or the bone, and you got to make that distinction. So if this were liver damage only, then the hyperbilirubinemia is going to be associated with normal serum calcium levels, but it would be elevation in your alkaline phosphatase, elevation of your AST, and elevation of your ALT. Okay. Now, because you have this as a voiceover presentation, you could easily go back and review what I just said. So, let me repeat this because it may come across confusing. Alkaline phosphatase, when elevated, could be due to bone damage or liver damage. If this were bone damage, the serum calcium would be elevated. If this elevated serum calcium is associated with a normal albumin globulin ratio, consider the possibility of bone metastases or healing bone fractures. If the hypercalcemia is associated with a reverse in your albumin globulin ratio 1 to 2, consider the possibility of primary bone malignancy in the form of multiple myeloma. If your alkaline phosphatase is elevated and your serum calcium is normal, then you are going to consider the possibility of there is liver damage. And that liver damage could be either due to hepatitis or it could be due to cirrhosis. How do you sort out the two? If the albumin globulin ratio is reversed, it is more likely to occur in cirrhosis, less likely to occur in hepatitis. Okay. Any questions? Now we have spent almost, what, more than an hour? Almost 2 hours on this? I don't know. Next we're going to look at is urine analysis. And remember, this is your routine urine analysis. I said to you in the first lecture, I repeated it once yesterday. I'm repeating this again. If for some reason you're suspecting that the patient's symptoms and signs and lab results are due to multiple myeloma, you need to order a separate test to find Benn's proteins in the urine. It will not be done in your normal urine analysis. Okay? So what is covered in the urine analysis and when should a urine analysis be ordered? Let's start answering the last question first. When to order a urinalysis? You order urinalysis when the urine is cloudy. Commonest cause of cloudy urine, bacterial cystitis. If the urine is red, not every red urine implies that there is hematuria. We'll find out later that red urines could be associated with certain red vegetables, beets, rhubarb. It could be associated with eating foods that contain a lot of artificial red dyes, and you pass that out in the urine. But more important, that red urine could be due to blood in the urine, hematuria, and you want to check whether the red color in the urine is actually due to blood in the urine, and then rule out from the history an additional test whether this is renal cancer or bladder cancer. You're going to order a urine analysis if the complaint from the patient or the patient's mother says little Johnny's urine when he pees in the toilet bowl causes a lot of bubbles to appear. Foamy urine might be uh, nephrotic syndrome, in which there's excess proteins in the urine, greater than 3.5 grams of proteins in a 24-hour period. And then the last, if the urine is dark green or brownish in color, this might be indicative of obstructive jaundice, and you're going to want to be able to go, okay, in addition to the bilirubin in the urine, what is happening to the urobilinogen? And we'll talk about again that in obstructive jaundice, even though there's bilirubin excess in the urine, there is going to be no urobilinogen in the urine. All right, so let's look at the dozen things that are going to be reported in a standard routine urinalysis. One, the lab tech report is going to say the color. The normal color is amber. If it is red, it could be actually due to blood or food dyes, either artificial or natural. They're going to report on the appearance. The appearance of the urine is clear. If it is cloudy, you need to think of, is this indicative of a urinary tract infection, otherwise known as bacterial cystitis? Three, they're going to report whether proteins are present in the urine. Proteins present in the urine could be nephrotic syndrome, it could be pyelonephritis or other kidney disorders, and they will report the amount, and there are 4 grades. Plus is a little protein, and if you move from 1 plus and you go over to the other side to the right, 4 pluses means there's massive amount of proteins, which is more likely to be seen in nephrotic syndrome. And then it would be an intermediate, so 2 pluses or 3 pluses. And you go, okay, this is more than normal. You should not see any proteins in the urine, and therefore any proteinuria should be referred to a medical doctor or the appropriate specialist, depending on what your diagnostic conclusion is. They're going to report on the presence of nitrites in the urine. Now, there are 8 bacteria. All 7 of them are bacilli. 1 is a coccus that are associated with causing urinary tract infections. I have to go back to some microbiology and bacteriology in particular, because it will help you to make sense of this patient has the symptoms of a urinary tract infection. She's a female because UTIs are more common in females. She has the complaint of burning when she passes urine. She's passing urine frequently. She gets up more than 2 times at night to pass urine, so she has increased frequency. She has dysuria and she has nocturia. You're putting money down. What are the odds? This patient has a bacterial cystitis. Send their urine off to be tested, and it comes back nitrite negative. And you're going, but wait a minute, I thought if you have nitrites in the urine, it's indicative of a bacterial infection, and if you don't have, then what does that mean? 7 out of the 8 organisms, and the 8 organisms, if you learned this properly with Dr. Justice or whoever is teaching you microbiology, you should have learned the mnemonic KEEPS. KEEPPSS. 8 organisms that cause urinary tract infection. So the K is for Klebsiella pneumonia. The first E is for Escherichia coli, E. coli. The second E would be Enterococcus faecalis. The first P would be Proteus mirabilis. The second P would be Pseudomonas aeruginosa. The first S is Sriracha marcescens, and the last S, which is the only coccus in all of these organisms, is Staphylococcus saprophyticus. And I want you to remember Staphylococcus saprophyticus, because in addition with this being the only gram-positive organism that causes urinary tract infection. It does not possess the enzyme called nitrate reductase. All of the other 7 organisms have in them the ability to produce nitrate reductase, which in the presence of nitrate will reduce the nitrate to nitrite, and then the nitrite would show up as a positive on the dipstick that is used in the lab. Staph saprophyticus is the second most common cause of a urinary tract infection in an actively sexually active female. Number 1 is E. coli. So please remember that Staph saprophyticus is nitrite negative. The next we're going to look at is the specific gravity. Specific gravity could be normal, could be low, or could be high. If it is low, consider a condition known as diabetes insipidus, or the patient has drunk too much water and the body is compensating by peeing out dilute urine. If the specific gravity is high, then consider the possibility of either dehydration or the patient is starting to have some problem with the kidney filtration system. They're not excreting enough water, and that could also cause an increased concentration and increased specific gravity in the urine. The lab will report the number of white blood cells seen per high-powered field, and it normally should be less than 3 to 5. If it is greater than 5 white blood cells in the urine sample looking under the high-powered magnification, this is indicative of an infection. If it's an infection, the lab is going to report whether there is no leukocyte esterase or whether leukocyte esterase is positive. Leukocyte esterase is an enzyme, an esterase enzyme that are produced by inflammatory white blood cells and is indicative of either urinary tract infection or, in a woman, contamination from a vaginal discharge. The vaginal discharge might be vaginitis or cervicitis associated with chlamydia or gonorrhea. The vaginitis could be bacterial vaginosis, candida albicans infection, and the discharge from the vagina spills over into the vulva, contaminates the urine, and leukocyte esterase will be present in the urine. However, in this particular situation, since the bacteria are not coming from the bladder, then it's unlikely to be nitrite positive. So if you have a situation where you have white blood cells, leukocyte esterase is positive, but no nitrites, then it's more likely to be a vaginal discharge contamination rather than a real urinary tract infection. The lab report will also contain whether there are red blood cells found in the urine. There should be no more than 3 to 5 red blood cells per high-powered field. If there are more than that, you have the laboratory confirmation that the red urine was due to hematuria. This could be seen in renal cell carcinoma, this could be seen in bladder cancers, or it could be seen with urinary stones. As the sharp stones pass through the ureter, it injures the inside lining, blood leaks into the urine, or you can see this with severe UTIs or pyelonephritis. Next, the lab report will make a comment on whether sugar is present or not. Sugar should not be present in the normal urine. All of the sugar that is filtered by the glomerulus into the proximal convoluted tubule, 100% of that sugar is reabsorbed from the proximal convoluted tubule back into the urine using a sodium glucose co-transporter mechanism. If there is sugar in the urine, consider the possibility of diabetes mellitus. of which you are going to then, if you haven't ordered a comprehensive metabolic panel, go back and look at the comprehensive metabolic panel and see if you've missed the diagnosis of diabetes mellitus. It could be Cushing syndrome. Cushing syndrome is going to mess with your sodium and your potassium, and it will give you glucosuria, which is the word for glucose present in the urine. Or if the patient is suffering from acromegaly, acromegaly has a similar effect on the blood sugar like Cushing syndrome sends the blood sugar up, but it may not send it up to the point of above 126 milligrams per deciliter. And then the last is a thiazide diuretic. Thiazide diuretics are used commonly as a first-line pharmacological treatment of patients with mild hypertension. One of the common side effects is it causes the patient to spill sugar in the urine. And I'll tell a story at this particular time. I had a patient many years ago when I was working in South Africa who accidentally came into the Department of Family Medicine. I said accidentally in quotation marks. She had lost her husband 3.5 years ago. And after the family got tired of crying morning, noon, and night for 6 months, they took her to the hospital. They passed her on to the psychiatrist who diagnosed post-bereavement depression, put her on a tricyclic antidepressant. This was back in the early 90s. And they were seeing her every 3 months. And part of their routine checkup in the 3-month checkup was check her blood pressure, check her urine, check her pulse, her temperature, and then ask her how she was doing. Continue using the screening tool that they were using for the severity of depression. And if she was good to go, they continued her on her medication, and she came back and saw them 3 months later. This went on for a couple of years, 2 years, and during one of the routine revisits, they found that her pressure was slightly elevated. Now, psychiatrists don't deal with anything but the mind, so any organic, organ-based disease, they go to the specialist. So the resident psychiatrist referred the patient to the hypertensive clinic. She went over to the hypertensive clinic. They confirmed that she had hypertension, put her on a mild dose, 12.5 milligrams of hydrochlorothiazide to bring her sugar down. And every time she came back for her 3-month visit, she would start off with the psychiatrist, go to the hypertension clinic, get her antihypertensive medication, get her antidepressive medication, and go home. Fast forward 3.5 years later, she goes back to the psychiatrist. They check, do their routine check. Blood pressure is now well controlled. There is 1 plus sugar in the urine. This could be diabetes mellitus. Refer her to, so she goes to her hypertensive clinic appointment, and she looks for the diabetic clinic, which happens to be in the same building. There was a row of buildings, and there was one short fence that separated the diabetic clinic entrance from the family medicine entrance. She walked into the wrong door. I was on duty, sat her down, talking with her, made the conclusion that she was suffering from something called polypharmacy, too much medication. She was put on originally 3.5 years ago an antidepressant. One of the uncommon complications of tricyclic antidepressants is hypertension. She was sent over to the hypertensive clinic. Diagnosis was made, put on thiazide diuretic, back to the psychiatrist, off the Department of Internal Medicine Diabetic Clinic, And I know that one of the side effects of hydrochlorothiazide is sugar being spilt in the urine. What happens is, let me remind you, there's a threshold that below which when sugar is spilling out in the urine, if the blood sugar levels are below 180, because sometimes you eat and you come into the clinic and you're not fasting, you've had breakfast, you've had a snack before because you've been waiting 3 hours to see the psychiatrist, your sugar might be a little up. That might spill out into your urine, but it's going to be cleared away by the sodium glucose transporters in the proximal convoluted tubule, except if it is above 180 milligrams per deciliter. Now, if you take a hydrochlorothiazide diuretic, it lowers that threshold from 180 to 120. You just had meal, you're going to spill sugar in the urine, and the dipstick is going to pick this up. So I made the conclusion that the sugar in the urine is not because she is diabetic. The sugar in the urine because it's a side effect of the chlorothiazide. She's on hydrochlorothiazide because she was diagnosed as hypertensive, but the hypertension was actually drug induced. So I took it upon myself because she was seeing me. She's now my patient. I am going to stop all medication for 1 week. I'm going to send your blood off right now. And when you come back in a week's time, I will look to see what your blood pressure is doing, if your urine still is having sugar, and I'll be checking your fasting blood sugar to see if it is below 126 milligrams per deciliter. She came back a week later. I could not recognize this patient. She was totally different. When I first saw her the week before, she had her head wrapped up in a scarf. Her shoulders were down. She had this, resigned attitude towards life. She walked in, but not actually dragging her butt, but not. Then I said to her, "How are you feeling? You look so different." She says, "Doc, I feel so different." Um, and then I said to her, "How were you feeling before?" And she's trying to find, because she's speaking a different language, and my nurse is interpreting South Sutu into English. She's trying to find the right words to explain it, and my nurse translates. She says, Mrs. Mabuso says, "Imagine that you have been wrapped up in wads of cotton wool and tied up with a loose bandage, like a mummy." And I recognized the zombie description. This was the day before the Living Dead zombie craze. And she says, "Is when you told me to stop taking all of those medicines, it was as if somebody had cut this bandage off. And Doc, I am no longer alive. I am living. I'm enjoying life." And that's just a lesson in polypharmacy. Now, I know you don't have the authority to stop medications, even though you might think the medications could be the problem. You need to send your patient back to her primary care physician or whoever prescribed the medication and ask them to consider changing the medication because of possible side effects. Sometimes, and this came out, I learned this from a board's question a couple of years ago. One of Irene Gould's questions had to do with which of the following gives a false positive for sugar in the routine urinalysis. And I was not aware of this. I had to Google this and found out that if you took more vitamin C supplements than you need, there is no place in the body where vitamin C is stored. It is passed out in the urine. And the ascorbic acid, which is the other word for vitamin C, the acid triggers the reagent found in that little piece of the dipstick that says sugar is present. So you need to be careful that a positive sugar test using a dipstick might indicate that it could be diabetes, Cushing's, or acromegaly, or it could be you're on some form of supplementation. There should be no ketones present in the urine. Ketones are present in two situations: diabetic ketoacidosis, which more often occurs in type 1 diabetes, or you are starving for a couple of days, or you're on one of those strange ketogenic diets where you don't take any carbs. Your body needs to get energy, and it's going to break down the fats and the proteins. If you break down fats through the process of beta oxidation, you are going to get three ketones: acetone, acetoacetate, and beta hydroxybutyric acid. Acetone is useless as far as going into the metabolism, and therefore is excreted in the lungs on change. Acetoacetate and beta hydroxybutyrate joins the Krebs cycle and is eventually converted into NADH or GTP or FADH2, and then when shunted to the mitochondria, you're going to get ATP from this. So you should not have ketones. If you have ketones, you need to consider diabetic ketoacidosis, starvation, or your ketogenic diet. Bilirubin is, you might find a little bilirubin, but if the patient is jaundice and there is no bilirubin in the urine, this is pre-hepatic jaundice. And then you go back, is this painful? Is this in a black child? Sickle cell disease. If it's painless in a white person, it is another form of hemolytic anemia. Urobilinogen should be present. And this is, as far as I remember, and I could be wrong, the only test result that is positive when the finding is negative. I hope that makes sense. It is of significance if there is no urobilinogen in the urine. When that is so, it is indicative of obstructive jaundice. And you go back, is there pain? Is there no pain? And then bacteria should not be present in the urine. If it is present, it's in a small amount. It may be contamination from the surrounding genitalia. The lab will report if there are more than 100,000 colonies per unit that they are examining. If there's more than 100,000 colonies, active colonies, then this is indicative of a urinary tract infection. We're not done. In your routine urinalysis, the lab would also report the presence or absence of urinary casts. There should be no casts present in the urine. If the casts are red blood cell casts, and they will tell, because they're not going to send you a picture to confirm this. They're just going to report red blood cell casts are present, and you go, okay, red blood cell casts present, pathognomonic as far as you and I are concerned, glomerulonephritis. There should be no white blood cell casts present. If white blood cell casts present, pathognomonic for pyelonephritis. If they have fatty casts where tiny little oval bodies or droplets come together to form these long tubular cast-like structures in the urine, fatty cast is indicative of nephrotic syndrome, and waxy casts are indicative of chronic renal failure. You are going to get a clinical vignette associated with one of these findings, if not in this first exam. But when we do urinary problems in week 13, in your final exam, you could get a clinical vignette of a patient with a urinary problem and one of these four pictures, and then 5 choices to choose, 2 correct choices. There should be no crystals in the urine. The presence of crystals in the urine is called crystalluria. If the crystals are hexagonal in shape, then it is crystals can form from cysteine. This could be as a result of an inborn metabolic defect, which is uncommon. The most common cause of crystalluria and therefore renal stones is calcium oxalate. And calcium oxalate crystals are described as envelope-shaped crystals. Uric acid crystals are often described as barrel-shaped. Uric acid crystals are going to be found in patients with hyperuricemia. Some patients with hyperuricemia will present with gout. Not every patient with hyperuricemia will present clinically with gout. And then the second most cause of urinary stones would be your triple phosphate, otherwise known as struvite. Your struvite stones are associated with this peculiar shape. They're called coffin lid shape. And I want to make another point about these particular stones because there could be a question that requires you to remember some detail from microbiology days. Triple phosphate stones or struvite stones are associated with Proteus mirabilis. Underline the U in Proteus mirabilis to help you to remember that Proteus mirabilis is a urease positive bacterium. And if you have urease being produced by this bacterium in a urinary tract infection, the urease will break down the normal urea that is expelled by the kidney functioning properly, and that urea is going to be further broken down into ammonium and carbon dioxide. The ammonium is going to then change the slightly acidic pH of the urine to alkaline. And once the slightly acidic pH of the urine is alkalinized, it will form staghorn calculus. So when we do abdominal pain later on, and I show you a patient with a urinary stone or a stone in the kidney, and it has a shape of a staghorn calculus, I will come back and harass you about what is the nature of the organism that is most likely to be associated with this picture. I'm not going to tell you this is staghorn calculus. I'm going to show you that picture. The boards might not use the image, but I understand from the recent boards examinations in part two is that they're putting in more and more images. Coffin lid, uh, envelope shape, uh, red blood cell cast, etc., etc. Okay. So let's pause and give you an example of an extended multiple choice question that is typical for part three. You will see here is a short clinical scenario. This is a 57-year-old male that is overweight. He is complaining of painless hematuria. He has had 2 episodes so far. And the only thing of significance is that there are numerous red blood cells in the urine, no white blood cells, no cast, no crystals. And here's the extended multiple choice question. Which 2 statements regarding this patient are correct? Select 2. A, he has nephrolithiasis. Now, nephrolithiasis is the big word for kidney stones. Do you think that a patient with kidney stones will have painless hematuria? Not painless hematuria. It would be painful hematuria as the stones are coming down the narrow ureter. It will cause loin to groin, severe loin to groin pain. So A is out. The most likely diagnosis is glomerulonephritis. Now, if this were glomerulonephritis, what would you have expected to be seen present in the urinalysis? You would expect to see red blood cell casts. There are no red blood cell casts, so no, the most likely diagnosis is not glomerulonephritis. Let's look at the urine. Urobilinogen is most likely to be present in the urine. Now, is that a normal finding? Yeah, urobilinogen is present in normal urine. The only time that you look for urobilinogen that is significant is when it is absent. So C is possibly correct, but maybe there are better options here. So let's look at D. Bladder cancer should be ruled out. So you got to go back in your pathology. Bladder cancers compared to renal cell carcinomas. Renal cell carcinomas are more likely to cause painful hematuria. Bladder cancers, traditional cell bladder cancers are more likely to cause painless hematuria, and therefore bladder cancer should be ruled out. And how do you rule that out? Not from the history or your physical examination. You need to refer this patient to a urologist, not a nephrologist. So because E says should be referred to a nephrologist, nephrologists don't deal with the bladder. Nephrologists deal with the kidney, the organ that contains 2 million nephrons. So he should be referred to a nephrologist is wrong. So your two correct answers are urobilinogen would be present in urine because that's a normal finding, and bladder cancer should be considered as a possible diagnosis. Any questions? We're going to take a break here and then come back later and do the next section, which would be lipid panel. The next group of blood results we're going to discuss is the lipid panel. When do you order a lipid panel, which could also be called a cardiac panel because they used to screen for cardiovascular diseases? If the patient has any one of these, coronary artery disease, whether myocardial infarction or angina pectoris, hypertension, a family history of high cholesterol in the family. It might be genetic, or as my boss would say, yes, this hypertension runs in the family, or the high cholesterol runs in the family, and he would add after he says, yes, it runs in the family, kitchen, implying it's not genetic. Your dad and mother have hypertension and high cholesterol, and you have high cholesterol because your mom's cooking is so delicious that you are overweight and you're likely to die from a heart attack. Obesity and diabetes are other high risk factors that are going to trigger your wanting to order a lipid panel or a cardiac panel, which will contain your total cholesterol, your HDL cholesterol, your LDL cholesterol, and your triglycerides. So total cholesterol is given, and then they give you a breakdown that out of the total cholesterol, this percentage is, or this amount is made up of high density lipoproteins or low density lipoproteins. The high density lipoprotein cholesterols, the higher you have, more you have HDLs, the lower your cardiovascular disease risk is. The low density lipoproteins, I think the way I remember this is H in HDL is for healthy, L in LDL is for lethal. Low density lipoprotein cholesterols increase risk of cardiovascular disease. Having said that, Dr. Krabbe will then delve into a lot more detail into Not all low density lipoproteins are associated with increased cardiovascular disease risk. You have two major groups, the big fluffy ones and the small dense tiny ones. It's the small dense tiny ones that are more damaging to your system and may even tell you to go deeper and order something called apolipoprotein A, but that is not part of the standard uh, lipid panel today in most medical offices. Your lipid profile will cover your triglycerides. Your triglycerides, if elevated, might show that there is an increased risk of cardiovascular disease. Depending on the circumstance, your lipid profile may extend into a cardiac panel, and in the cardiac panel, there would be your cardiac enzymes. These enzymes include troponin, creatine kinase MB, and lactic acid dehydrogenase. These are chemical compounds that are a natural part of the makeup of the myocardial cells. And as long as the myocardial fiber is intact, then these enzyme levels or these levels are zero in your blood. When you suffer from an acute myocardial infarction, you suffer from coagulative necrosis. The myocardial cell ruptures and releases these naturally occurring intracellular components into the bloodstream. And therefore, if you have elevation in your troponin, particularly troponin C, elevation in your creatine kinase CKMB, MB stands for myocardial band, or lactic acid dehydrogenase, you have evidence of myocardial infarction. So they're going to be raised in an MI. They're going to be normal in angina pectoris because in angina pectoris, the cells do not die. They suffer from ischemia, they have hypoxia, but not anoxia because the patient gets the chest pain, sits down, takes a breath, and waits about 10-15 minutes, and then he's ready to go on his walk or do whatever he was doing before the ischemia triggered the chest pain. Neither are these enzymes raised in angina pectoris, nor are they raised in pericarditis. Pericarditis might give you a similar presentation of pain in the precordium, but unlike myocardial infarction and angina pectoris, in which the pain is going to be squeezing, we're going to relearn this again when we do chest pain in a couple of weeks. The pain in pericarditis is sticking in nature rather than squeezing in nature. Additional cardiac tests might be ordered depending on what the diagnosis is. One of the hormones that are produced by stressed ventricles is a hormone called B-type natriuretic peptide. There's another one called A natriuretic peptide. And A natriuretic peptide comes from stressed atrial tissue. B-type comes from stressed ventricular tissue. If you see the word natriuretic and look at it and break it up in its two Greek origins, natrium is the chemical word for sodium, from which we get the symbol Na from natrium. Uretic is the latter part of a diuretic. So when you put natrium and diuretic together, it is telling you this B-type peptide is going to cause diuresis and is going to work on the proximal convoluted tubule to prevent the reabsorption of sodium, and therefore the kidney excretes more sodium into the urine. Sodium coming out in the urine pulls water with it, and the body is producing their own mild diuretic. If the value is greater than 400 picograms per deciliter, it is indicative of the possibility of a congestive heart failure. But look at the specificity. Specificity is only 76%. So we really can't use this particular test to diagnose uh, congestive heart failure, but because the sensitivity is 90%, we could use it to rule out. So this is a good screening test based on the sensitivity and specificity. You probably are asking yourself, what would be a good confirmatory test? We'll talk about that later. It happens to be the echocardiogram, where they actually work out how much of the 110 or 120 cc's of blood in each ventricle are expelled after the end diastolic volume, how much is squeezed out, and if it is less than 40% of the 110, that's the gold standard for the diagnosis of congestive heart failure. But we'll pick that up later when we cover it on the miscellaneous tests. As I said, an additional test that some doctors are ordering is the ApoB, which stands for apolipoprotein B. They have found that this particular type of low density lipoprotein, which is a very dense small molecule, is atherogenic. The word atherogenic means it is linked to the genesis development of atherosclerosis. The normal value between 50 and 125, and it's a much better tool today to assess the risk of a patient having a cardiovascular event. It is in red. Red here does not mean that this is important and you will be tested. Red means is this is new information. It is good for you to know going forward, but it will not be on your exam, neither in this class or in boards, until another possible 5 years when it hits the traditional medical text and everybody is now doing this. Any questions? If there are no questions, we are going to the next test that is in the cardiac disease domain. So we talked about lipid profile, we talked about the cardiac enzymes, we talked about the B-type natriuretic peptide. Now we're going to look at another investigative tool which is going to help us to determine a number of conditions. So from a primary care perspective, when should an ECG be ordered? If you suspect myocardial ischemia presenting as angina pectoris. Myocardial infarction, you're not ordering this test. You're calling 911, and when they get to the hospital, the ER docs is going to do this particular ECG. Don't send this patient out to the next door cardiologist to, you're suspecting that him clutching his right hand over his left chest is a myocardial infarction. You're calling 911. So myocardial infarction, angina pectoris, pericarditis, which could be confused clinically in the clinical picture, or the patient says, my heart seems to be skipping a beat, or every now and again I feel a thump in my chest. And the weirdest patient complaint I had that that led me to believe, no, this is a arrhythmia. The patient said to me, something is wrong with their heart. I'm going, good. Why do you think something is wrong with your heart? I don't know how to describe this. Try. I'm not giving them any choices. And she says, she was a housewife. And she says, Doc, when you put a bowl of jello to set and you turn it over because you want it to be part of a decoration for the dining table, and you're going to take your finger and you're going to jab the jello, and the jello shivers, shakes inside. That's what it feels like. And I said, hmm, that's a very good description of what I think you have. Checked her heart out, uh, stood there for, I said, going to be here a while, 3 minutes. And then sometime after the second minute, there was the beat was not regular. So hear this and imagine you're feeling this. Boop, 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 boop. So there was a normal rhythm, boop, boop, boop. Then there was a prolonged pause, boop, boop, boop. And then the beat that came after was a bit more forceful. And I said to her, "You just had one." She says, "Yes." I just felt my heart wobble like jello. So two arrhythmias. There are more than 2 dozen arrhythmias. I'm not going to bore you with any of them. Just going to do two of them because boards concentrates on this: atrial fibrillation and the Winkelbach phenomenon. So ECG is ordered. Just going to review. Not going to test you on this because that's part of your normal physiology, but I'm going to test you on the abnormal findings. You know that your normal ECG has PQRST. Sometimes the U would be stated. The P is the first positive deflection. The Q is the first negative deflection. The R is the second positive. The S is the second negative. And then you have straight along what is called the isoelectric line. And then the third positive deflection would be your T wave. And if it's not always present, most ECG waves that I have looked up for don't have the U wave. If you put in "I want a U wave," it will tell you here's an ECG with a U wave, and most of them are associated with potassium imbalance. But you need to know it could occur in a normal patient, and it's the 1, 2, 3, fourth minor positive deflection. You should also know that the PR interval is not between the P wave and the R wave, it's actually between the beginning of the P wave and the beginning of the Q wave. The QRX complex is obviously between the Q and the S waves, QRS, and then you have a distance between the S wave and the T wave, and that's called the ST segment. So we're going to talk about P waves. We're going to talk about prolonged PR waves. We're going to talk about wide QRS complexes, and we're going to talk about either ST elevation, ST depression, T wave inversion, and we're not going to talk about U waves, not in this discussion. Okay, so what abnormal ECG findings you need to be familiar with? One, the ECG findings, three of them, even though there are four, boards only concentrates on the second, third, and fourth. They rarely talk about, I've not seen a question about hyperacute T waves, but because the hyperacute T waves happens within the first 10 minutes of the ongoing myocardial infarction. By the time the patient sits down, waits the 10 minutes and thinks, nope, darling, I don't like how I feel, call 911. By the time you get to the ER in the hospital, it's a half an hour, and then the hyperacute T wave is replaced by ST elevation. So ST elevation is the first thing that you should be remembering. The ST wave is elevated above the normal isoelectric point through which your P runs. The next thing that happens is that there's an inversion of the T wave. The third thing that happens as the myocardial infarction progresses to the point of this is it, the tissue is dead, pathological Q waves. The Q wave is a small negative depression when your Q wave is 2 or 3 times the normal depth. That's a pathological Q wave. As the person recovers, so we assuming the patient got to the hospital in time, they diagnosed with an emergent coronary angiogram that the main branches of the left coronary artery are affected. The right coronary artery is good. This patient is either going to need a triple bypass or a quadruple bypass, depending on the number of arteries and branches affected. They get in there, they do the bypass or they put in the stent, the patient recovers, and over the next 6 months to a year, the T wave inversion improves, the ST elevation disappears, and all that is left as evidence of you've had a heart attack within the last year is the pathological Q wave. The deepened pathological Q wave is the only remnant of you've had permanent damage to your myocardium. We need to get your blood pressure and your cholesterol and your diabetes and your weight under control. We need to stop smoking. The other ECG finding is related to angina pectoris. Angina pectoris, there will be ST depression. Do not confuse myocardial infarction, which causes ST elevation, with angina pectoris, which causes angina pectoris, and the depression of the ST segment only occurs during the episode. If you're not having ischemia right now because you've been sitting there in the office for the past hour waiting for me to do an ECG, it's not going to show any ST depression. But based on the history that you have of squeezing chest pain made worse on exertion, relieved by rest, I am sending you off for an urgent appointment with a cardiologist, even though today your ECG looks normal. What the cardiologist is going to do is hook you up to a 12-lead ECG machine. He's going to stress you. In my days, they used to put us on or put the patient on a treadmill and have them run for the next 5-10 minutes until the patient's heart is stressed and we see the ST depression that you can see in the EKG. Today, they put you on the examination table, they put an IV drip in you, and they inject you with a certain chemical which within 5 to 10 seconds will cause your heart to race like the blaze. It will go from bup, 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 and they will tell you take a deep breath. It will last for a couple more seconds, and then you're good to go. And they're looking on the ECG to see when your heart rate has gone up from 70 to 110. This is going to induce the ischemic episode, and they will see the ST depression on the stress test. The third disease that you could be tested on in the examination, my exam boards part 2 and part 3, is pericarditis. You're going to get, watch this, ST elevation, that's a myocardial infarction, T wave inversion, 2 ticks, no pathological Q waves. If this occurs in the ER, what the doctor is going to do, he would have taken, there's a protocol in the ER. You come in there with chest pain, everybody and his uncle at work there knows what to do. Somebody's going to guide you to a room. Somebody is going to come in and hook you up with the 12 leads. Another person is going to come in and put a drip in your left forearm. Another one is going to come in and take blood from you from a vein in the right forearm. The doctor comes in 10 minutes later. He looks at the ECG. He sees ST elevation, T wave inversion. He chats with you, and he hears from you that chest pain is sticking in nature and you had a history of what looked like a viral infection a day or two ago. He is thinking, this might be pericarditis, so just let's be sure. We're going to keep you hooked up to the monitor. We're going to send this first blood off to the lab, and we are going to then wait until the lab results come back. Lab results come back 20 minutes later. Troponin is normal. CKMB is normal. Lactic acid dehydrogenase is normal. They're going to go, good. We're going to keep you in for another hour. We're going to repeat this in an hour's time. And if everything is normal and you don't have pathological Q waves or evidence of enzymes spilling into your blood, we're going to refer you to the cardiologist on call for an appointment, or for him to decide, is he going to admit you or what? So let's do this again. Pericarditis looks like, but could be differentiated from acute myocardial infarction, AMI, from the history, depending on the description of the pain, confirmed by finding on the ECG ST elevation T wave, but no pathological Q waves. The first of the two arrhythmias would be atrial fibrillation. Atrial fibrillation, patient will present with uh, a thump occasionally in my chest. This could be seen with hyperthyroidism, whether it's associated with Graves' disease or not. It is a common manifestation after cardiac bypass. A couple of years later, you may develop atrial fib. When you are actually having atrial fib, because it doesn't always manifest as and then you're going to have it for the rest of the day. It comes in, you have a bad run for a minute or two, you're good for the next day, you ignore this, it comes back a week later, and then the frequency is a little more frequent. It was once a week, now it's twice a week, now it's 3 times a week, now it's every day. No, I'm going to see my doctor. And if he happens to examine you at the time you're having atrial fibrillation, the pulse would be irregularly irregular. So here's what a regular pulse feels and sounds like. Lub, dub, lub, lub, lub. And I'm making it a hard sound, so let's go bup, 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 bup. Normal. Here is what AFib feels like. Bup, 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 bup. So it is irregular, but it's not regularly irregular. It is irregularly irregular. And if they do this, ECG at the time, this is what they're going to see. Absent P waves. They're going to see what is known as a sawtooth appearance. Okay. And the next abnormal ECG finding is related to a phenomenon known as Wenckebach's phenomenon. This is a heart block. They are first-degree heart blocks. They are second-degree heart blocks. And in the second-degree heart blocks, there's a Mobitz type 1 and a Mobitz type 2. Again, you're not going to see ECGs in your exam. With my exam or parts 2 or 3 or 4, you're going to see words. And here is the pattern recognition of the words that when you see the following description, progressive prolongation of the PR interval, 3 Ps, you are dealing with Wenckebach phenomenon, which is a heart block situation where there's a disconnect between the SA node located in the right atrium just below where the superior vena cava comes in, and the AV node, which is located close to where the coronary sinus drains. The AV node doesn't actually lie between the atrium and the ventricle. In no man's land, it lies in the bottom part of the right atrium. And if that impulse is not coming through directly from the SA node to the AV node, then you may get what is known as a Wenckebach phenomenon. So occasionally what would happen is that you would have a drop beat. So if you look at this ECG following, you can see Boop, 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 boop. 3, 4 beats, regular. There's a pause there, and then it starts back again. Boop, 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 boop. Pause, starts back again. So it drops a beat. This is usually a benign condition, but you would have referred this patient to a medical doctor or a cardiologist, and they will deal with this. All right, so let's look at another example of a part 3 extended multiple choice question. This is a female. She's 67 years of age. Um, Her pulse rate is high, so she has a tachycardia. She complains of episodes of palpitation starting 3 months ago. She has unexplained weight loss, and she complains every time she has these episodes of her heart racing. She feels a little lightheaded and she goes and sits down or lies down until this passes. On physical examination, she's not overweight. Palpation of her radial pulse shows an irregularly irregular pulse. Examination of her neck shows a multinodular goiter. I don't have anything here to suggest that she has bilateral exophthalmos, so its absence is very significant. If the board's question does not put a specific finding that you are looking for, that if this were there in the clinical vignette, you could make this diagnosis. If it is not there, you can comfortably believe it is absent. ECG confirms the tachycardia, but the pattern is sawtooth. So I've given you enough information there to one, make the diagnosis and determine what is the possible cause or how you're going to manage this patient. So here are the questions. Which two statements regarding this 67-year-old female with irregularly irregular pulse and a multinodular goiter are correct? A. She has atrial fib. Does she have atrial fib? Yes. What's the indication here? Sawtooth pattern. The most likely diagnosis is Graves' disease. Do you have any features of Graves' disease here? Graves' disease, if you remember, and I'll teach this later in a couple of weeks' time, tachycardia due to excess thyroxine, bilateral exophthalmos, and a diffuse goiter, not a multinodular goiter. So this patient does not meet the criteria for Graves' disease because they don't have one, bilateral exophthalmos, and two, they don't have a diffuse enlargement of the thyroid gland. They have a multinodular thyroid gland. So A is correct, B is not. T4 is going to be markedly decreased. We know that there's a thyroid problem here. We think it is not Graves' disease. It might be some other cause of hyperthyroidism. And if we think the diagnosis is hyperthyroidism, T4 will not be markedly decreased. It would be markedly elevated. In fact, a marked decrease in T4 is equivalent to myxedema. Myxedema is going to cause the opposite on the heart rate to hyperthyroidism. Hyperthyroidism causes tachycardia. This one will cause bradycardia, and this patient has a pulse rate of 110 beats per minute. That is not bradycardia. She should be referred to a cardiologist. And you go, yeah, possible, because she has a cardiac problem. But remember, if you find your two answers, don't turn the page or press the button and go to the next question. Look and see if the other remaining choices might be a little more correct than the one you just thought. Oh, she's going off to a cardiologist because she has palpitations and irregular pulse. Refer to an endocrinologist. And there's a toss up between should I send this patient to a cardiologist or an endocrinologist? If you sent this patient off to the cardiologist looks at this patient, looks and finds that the T4 is markedly elevated, he's going to go, I could make some money off of you by treating your atrial fibrillation, by taking you into the cath lab in the hospital, and $140,000 later, I have completely destroyed the connection between your SA node and your AV node with balloon ablation, and I don't treat the multinodular goiter and the possibility that this could be hyperthyroidism, I am doing you a disfavor. So no, your doc did well in referring you to a specialist, but I'm going to send you over to an endocrinologist for them to look at your thyroid function. So the correct answer here is not D, even though at some stage the patient might be referred to a cardiologist if the endocrinologist can't manage the atrial fibrillation by dealing with the hyperthyroidism. Okay, so some of those questions in part 3 might be a little difficult and you need to think this through. You're not going to get 0 if you got only 1 out of the 2 correct answers. You're going to get only half of the score for that question, not the full score. Okay. Are there any questions at this particular time? If not, we're going to take a break, come back later. Welcome back. We're about halfway through this 2 weeks of lectures. Today we're going to look at a group of tests collectively known as the arthritis panel. It could be 4 or 5, or it could be much broader than that, depending on the lab. So, when should an arthritis panel be ordered? Obviously, if there is joint pain. Common causes of joint pains that we have to know for boards would be rheumatoid arthritis, SLE, Sjogren's syndrome, the 4 HLA-B27 arthropathies, and gout. The arthritis panel obviously will contain rheumatoid factor. Rheumatoid factor is actually IgM, if you want a way to remember this. On the line, the M in rheumatoid factor. For IgM, it's an IgM antibody against an IgG antibody. So this is a antibody complex related disorder. Obviously, rheumatoid factor is going to be present in patients with rheumatoid arthritis. 70% of patients with classic rheumatoid arthritis would have a positive RF, rheumatoid factor, and much less so in patients with Sjogren's syndrome, SLE, and scleroderma. If you were looking for a confirmatory test for rheumatoid arthritis, you need to be ordering the anticyclic citrullonated peptide test, which has a much higher specificity for rheumatoid arthritis as opposed to the rheumatoid factor. For the 4-HLA-B27 conditions, obviously ordering an HLA-B27, which is an antigen test. Patients with psoriasis, 20 to 30% of patients with psoriasis would have a small joint arthropathy. Patients with 2 specific gut-related problems, Crohn's disease and ulcerative colitis, may present with back pain, particularly starting off in the SI joint region. So this would be enteropathic arthropathy. 90% of patients with ankylosing spondylitis would have a positive HLA-B27 antigen present. And patients with reactive arthritis, these are patients who may have been in contact previously with chlamydia organisms or Shigella organisms, may then develop a reactive arthritis that affects joints in the lower limb. Mainly, they would present with conjunctivitis and urethritis. And remember, the syndrome collection of symptoms in reactive arthritis is remembered by the can't pee, can't see, can't dance with me mnemonic. And then uric acid. If you have a patient with sudden onset of big toe pain, in particular the first metatarsophalangeal joint flares up after a bout of alcohol, or sometimes triggered by eating certain rich foods that contain purine or drinks that contain a lot of purine, will present with early morning severe pain in the big toe region, and by the time they are seen in the office by you, the big toe is swollen, it is red and very painful. Sometimes in these patients, when you take their blood test for uric acid, the uric acid level might not be elevated, but that's not the gold standard for gout. The gold standard for gout is actually aspirating the fluid found in the inflamed joint, looking at it on the microscope with polarized light and finding birefringent negative needle sharp crystals. Other tests would depend on if you thought that this was specifically lupus. The test specific for lupus is your double-stranded DNA antibodies. If you thought that this was Sjogren's syndrome, the SSA or SSB antibodies are going to be positive, and if you thought this was scleroderma, then there would be anticentromeric antibodies present. Any questions? Next, we're going to look at a group of tests under the common heading thyroid function tests. And obviously, thyroid function tests should be ordered if you suspect myxedema, Hashimoto's thyroiditis, Graves' disease, or if the patient has had his or her thyroid completely removed for whatever reason, treatment of cancer or treatment of uncontrolled hyperthyroidism. They will go into post-surgery immediate myxedema, and you may want to confirm that when you have placed these patients on replacement thyroid hormone therapy, that it is maintained at a level that is adequate for the patient's age and sex. So let's look at each of these in a little more detail. Myxedema. Myxedema is the term used for hypothyroidism in adults. Does anybody remember what is the name given for hypothyroidism in infants? It's called cretinism. Same test will be used, but with a different set of lab values. So myxedema, adult form of hypothyroidism. When you order your thyroid function test, it would include T3 levels, T4 levels, TSH levels, and certain antibody tests, which we will talk about shortly. The antibodies that are going to be present in patients with myxedema would be antibodies against thyroglobulin. Remember, thyroglobulin is contained in the uh, secretions found in the thyroid follicles, and in thyroglobulin is where iodine is going to be coupled with tyrosine, and that forms MIT, monoiodotyrosine. Two MITs are combined together to form diiodotyrosine, and two of those will then combine to form tetraiodothyronine, and then you take off one of the four iodine molecules out in the periphery, and you have your active form called T3. The other antibodies that are likely to be associated with some causes of myxedema would be thyroid peroxidase antibodies, TPOAB. Thyroid peroxidase is the enzyme that is going to allow iodine to be coupled with tyrosine in the thyroglobulin molecule. Graves' disease, on the other hand, is hyperthyroidism, again in the adult, but specifically associated with bilateral exophthalmos. And in Graves' disease, this is what you will find when doing the thyroid function test. T3 and T4 will be high, and because there's this negative feedback loop from the thyroid gland back to the pituitary gland, the anterior pituitary lobe, then your TSH is going to be low. Graves' disease is also associated with TSH, thyroid stimulating hormone receptor antibodies. And because these antibodies, even though Graves' disease is a classic type 2 hypersensitivity reaction, the antibodies don't destroy the TSH receptors. It actually sits on it in such a way that it stimulates the thyroid gland. So an alternative name for thyroid stimulating receptor antibodies is thyroid stimulating immunoglobulin, abbreviated TSI. Any questions? Okay, we're going to spend some time looking at a large group of tests called, or under the umbrella, serological tests. We're actually looking at the serum rather than the cellular part of the blood. So you will allow the blood to sit in a large tube with a red top, and then decant out the serum, and then do these particular tests on the serum. So what are these serological tests? These are diagnostic tests that are going to be used to identify specific antibodies in the serum. The purpose of doing these serological tests is either identify current infection or past infection by specific microorganisms. The majority of them would be viruses, but they could also cover bacteria, fungi, or protozoa. It also could be used in vaccination monitoring if you want to find out whether a new vaccine is capable of stimulating a strong immune response, like with the new COVID-19 vaccines, or they're experimenting with vaccines against chikungunya more recently. And you want to see how effective your vaccination program is, they will be testing the blood for antibodies against the particular antigen that is included in those vaccinations. Another way that serological tests are used, usually by places like CDC or the Department of Health, is for disease surveillance. To see whether the disease is on the rise, the disease is on the decline, or the incidence is at an endemic level. And lastly, especially with the more recent pandemic, COVID-19 pandemic, uh, serological tests were used to determine whether you were ready to go back to work. Now, there are 7 types of serological tests. There are precipitation tests, there are agglutination tests, there are tests that identify particular antibodies using a fluorescein dye that you can see under special lighting. There are neutralization serological tests, hemagglutination, where you're using blood as part of red blood cells as part of the hemagglutination test. And then there are immune assays like the ELISA test. ELISA is not a specific test, it's a type of test. The word ELISA stands for enzyme linked immunosorbent assay. And many of the ELISA tests are used as screening tests for HIV/AIDS, chlamydia, Lyme disease, and other such infectious or communicable disorders. And then there's the immunoblot test, otherwise known as the Western blot, which is used as a confirmatory test again for HIV/AIDS, Lyme disease, etc. Any questions? All right, so let's look at the various types. 7 of them. I'm going to give you at least just one example of this is a precipitation test or this is an agglutination test. You're likely to get one particular question in the first exam on, if I mention the electrophoresis for the M spike in multiple myeloma. This is a precipitation test where you pull the immunoglobulin out of the serum, precipitate it out by a process known as serum electrophoresis. You're going to take the serum, you put it on a specially prepared strip of blotting paper, you attach a positive and an electrode at the 2 opposite ends of the paper. You apply the current, and then over a specific time, different immunoglobulins, IgA, IgM, IgE, D, and GAMED5 will separate out at different times because each of them have a different weight. The heavier ones are going to precipitate out early. The lighter ones are going to precipitate out later. So electrophoresis, serum electrophoresis for multiple myeloma is an example of a precipitation type of serological test. When you do blood typing, whether it's ABO or rhesus blood typing, they use an agglutination test where they look for antibodies in the serum, matching it with antigens on the red blood cell. And if the red blood cells clump together, agglutinate, then it means this body has this particular blood type. The VDRL test, Coombs test, and monospot, which we will talk about later, are all examples of agglutination type of serological test. Immunofluorescence, the one that comes to mind is the confirmatory test for infections caused by Treponema pallidum or Treponema organisms, including Treponema pallidum. This is the fluorescent Treponema antibody absorption test, shortened as FTA-ABS, but this is the confirmatory test for syphilis. An example of a neutralization test is the test for dengue. Dengue has been up and down worldwide in the last couple of years. There's a current outbreak out in the Pacific that will do the rounds shortly from the Pacific to South America, up Central America, in the West Indies, and in a couple of months, there might be sporadic outbreaks of dengue in the United States, especially in the southern states. An examination of a hemagglutination test is the specific test for what type of influenza virus. Remember, we used two letters when you were learning which influenza virus is it. H1N1, H5N4, etc., etc. The H in the H1N1 is for a hemagglutination inhibition test. The N is for neuraminidase. And this is how they type the various viruses associated with influenza. Or examples of immunoassay would be the beta-HCG for pregnancy, or if you suspected the patient having been pregnant, had an abortion, uterus is still enlarged, and if you find serial testing of the blood that the beta HCG is still being produced increasingly, you can possibly conclude that there is chorionocarcinoma in the uterus. The ELISA tests for HIV, Lyme, Epstein-Barr virus all use the immune assay, and this would be the ELISA. Remember, ELISA is for enzyme-linked immunosorbent assay, and also used for the various types of viruses that are known to be associated with hepatitis. The immune blot would be your Western blot for the same conditions: HIV, Lyme, Epstein-Barr virus, and hepatitis. As I said, you're likely to get just one question on which of this is an example of X. Any questions? We're going to look at sexually transmitted infections and look at specific causes and see how syphilis or gonorrhea or chlamydia is identified in the lab. The first test that was dated back in the 1960s, 1970s, developed by a particular research laboratory researching various kinds of venereal disease. The first screening test for syphilis was called the VDRL test. VDRL stands for Venereal Disease Research Laboratory, and the screening test is an agglutination test. The FDA-ABS is an immunofluorescent test that is used to confirm syphilis. The ELISA HIV is an immunoassay screening test for HIV infection, and then your Western blot for HIV is the confirmatory test for HIV AIDS. There's another test that is used in the lab to distinguish between chlamydia and gonorrhea. Both of these, when it affects the males, produces a urethral discharge. Chlamydia produces a mucoid watery discharge, while gonorrhea produces a thick yellow purulent discharge. There's a big fat red asterisk next to the ligase chain reaction, and this is because this particular test, the ligase chain reaction, even though it is covered under sexually transmitted infections, is not a serological test. And I'll explain what kind of test is it. The ligase chain reaction test is a type of NAT, and NAT is the abbreviation for nucleic acid amplification test. It's not a serological test. They extract DNA or RNA material from the sample, and is primarily used for rapid screening in the healthcare system for diagnosing chlamydia or and gonorrhea. Now, when I trained as a medical doctor, and for years, 20 to 30 years after I graduated, it didn't matter whether this was chlamydia or gonorrhea because both of them were treated successfully by the use of doxycycline. Unfortunately, in those 30 years, gonorrhea started to develop a resistance to the tetracycline antibiotic called doxycycline, and they had to then find different uh, second and third generation antibiotics in order to deal with the doxycycline resistant gonorrhea, and therefore there's no one drug that you can use to cover both of them. You need to be able to identify and separate out that is chlamydia or this is gonorrhea. Okay. Any questions? Now let's look at more than a dozen specific serological tests in a little more detail. And this is arranged in alphabetical order. This is not arranged in the form as to whether this is an agglutination test or a precipitation test or a fluorescent antibody. This is arranged now in alphabetical order. So the top of the alphabet is beta HCG. This test is ordered when somebody thinks they are pregnant and you want to confirm that they are pregnant. It is also used in other situations, like there's about 10% of patients with the most common type of testicular cancer, which is seminoma. 10% of patients with seminoma will produce positive beta HCG. And I'll remind you of a story that you probably would have heard from two or three different teachers here. Years ago, and this is I think in the last 10 years, a young man posted on Facebook. He had broken up with his girlfriend and he was throwing her stuff out of his apartment, came across an unused pregnancy test, and for fun, peed on the pregnancy test and looked at the result, and the result said, "Whoa, you are pregnant." And he thought, yeah, this is great. Posted on Facebook, "Hey guys, this is what happened. I'm pregnant. LOL." And somebody posted on his post that if you're not, being an idiot, and this is actually true, please go urgently off to see your medical doctor because you may have something wrong with your gonads. And then he came back 3 weeks later, whoever you are, bro, thank you so much. Because it turned out that I had early testicular cancer, and with radiation and orchidectomy, I am good to go live a normal life. Thanks, bro. Um, if a woman has had a miscarriage and the miscarriage continues to bleed and she goes to the hospital and they do an evacuation of her uterine contents, then they found bunches of grapes, appearance of these distended vesicles. One of the things they will do is follow the curettage, the clearing out, evacuation of the uterine contents with weekly serial beta HCG, because hydatidiform mold, which is a benign condition, is associated with an increase in your beta HCG in the serum. And if the beta HCG does not come back down to zero, then the specimen would be looked at again for the possibility of, is this a malignant variety of the hydatidiform mold called choriocarcinoma? So they are 4 conditions that you need to remember that are associated with a false pregnancy test. The Coombs test is a test that checks for autoimmune hemolytic anemia. And the 2 classic examples of immune hemolytic anemia would be rhesus or ABO incompatibility. The monospot, which is a heterophile antibody test, uses horse red blood cells. This was the original test 40 years ago for infectious mononucleosis. The word heterophile implies that the antibody test is going to use other tissue besides humans. So in the monospot test, they are actually going to use horse red blood cells. And the original test, which was Paul Bonnell, which predates the monospot, similar heterophile antibody test uses sheep red blood cells for the diagnosis. Other serological tests, we talked about these already. There are tests for hepatitis A, hepatitis B. Hepatitis A only causes hepatitis. Hepatitis B causes hepatitis and hepatocellular carcinoma. And Hep C is associated with hepatitis cirrhosis and hepatocellular carcinoma. Next would be the anti-streptolysin O titer. If this is positive, and it is positive if it is greater than 200 Todd units in the serum, it is indicative of recent streptococcal infection, and by recent, in the last 2 to 3 weeks. So let me remind you what happens when your body is invaded by a particular streptococcus organism known as strep pyogenes. Strep pyogenes could get through your defense system by coming through the tonsils, causing a strep sore throat, or in developing countries, insect bites, mosquito bites on the arms or legs, and you scratch them with dirty fingernails. The strep pyogenes could come through cracks in the skin and cause impetigo. Now, one of the ways this particular organism enhances its ability to cause real problems, which is virulence rather than pathogenicity, is that this particular organism secretes 2 poisons or toxins, streptolysin O and streptolysin S. Streptolysin will tell you a lot about this poison. It's a lysin. It causes lysis, breaking. It breaks down red blood cells. It breaks down tissue. And strepto implies it comes from the streptococcus. The difference between streptolysin O and streptolysin S is that streptolysin O is antigenic and streptolysin S is not. Now, remember what is the word antigen. Where is it coming from? Antigen is actually 2 words that are mashed up together, and the 2 words are antibody generating. So we've taken the anti from antibody and we've taken the gen from generating. Put them together and we get antigen. So an antigen is capable of stimulating the production of antibodies. Streptolysin O is antigenic, streptolysin S is not. And therefore streptolysin S that does the same destruction of tissues and red blood cell once it gets into the body will leave no mark. Streptolysin O will induce antibodies which you can test in the serum 2 to 3 weeks later, because this infection can cause 2 diseases that could be potentially fatal. One, in children. Both of these are in children. The presentation is fever with joint pains, and that would be rheumatic fever, or the the immune complex between the antigen, which is the streptolysin O antigen, and the streptolysin O antibody comes together, forming an antigen antibody complex, which will then go and be deposited in the glomerulus, causing inflammation by triggering the complement cascade. And next thing you know, you have post-streptococcal glomerulonephritis. So in those two scenarios, rheumatic fever and glomerulonephritis, you may want to order the ASOT, anti-streptolysin O titer, to document that this is triggered or was triggered by a recent streptococcal infection. The enzyme-linked immunosorbent assay, ELISA for short, is a test that looks for specific antibodies using an immunoassay method. We've talked about this before. This is a good screening test for HIV, Lyme disease, or chlamydia. The Vidal test, I know it's spelled Vidal, but this is German, and therefore the W is pronounced like V. The Vidal test is an agglutination type of serological test that is used to confirm the presence of Salmonella typhi, which is the causative organism for typhoid fever. Another bit of information. Lyme disease, HIV infection, chlamydia, the tests that are done in the lab are called two-tiered test or testing. In my days, it was separate. If I suspected a patient having Lyme disease or contracting HIV, I would order an ELISA test, goes to the lab. A week later, the result comes back. The patient is positive for Lyme disease or for the HIV virus. Suggest you order the confirmatory Western blot test. Today, they skip out that come back to the doctor and then reorder another test. So this is a two-tier test that if the screening test, the ELISA test, is positive, then the lab goes directly on to do the confirmatory Western blot test. The first test, the ELISA test, has a very high sensitivity, 90% and above, and the second test, which is the confirmatory test, is very specific. And in the case of HIV, the Western blot confirmatory test, it has a specificity of 99%. Any questions? All right, now we're going to look at testing another group of specimen. We're going to be testing the stool. When do we order stool tests? And what stool tests should we order? There's a stool test called fecal occult blood. The term fecal occult blood tells you it's a test for blood that is hidden. That's what the word occult means, in the feces. If a patient says to me, "Doc, I have been seeing for the past week bright red blood in my stool," I am not ordering a fecal occult blood because it's not hidden. The patient has seen it. They have reported it. I do the rectal examination. I see bright red blood on the fingertip of my gloved finger, and therefore I don't need to do an FOB, fecal occult blood. 330. Another term for the fecal occult blood that boards use, Part 2 in particular, is the Guaiac test. This is a particular test. The fecal occult blood test is a test for colorectal cancer. It's a screening test. You collect the stool sample, you take it to the lab, They're going to mix it with some saline. They're going to spin it down, and they're going to do various tests in the lab, including fecal occult blood. The fecal occult blood or guaiac test has a low sensitivity but a very high specificity. Therefore, if a patient presents with um, let's see, unexplained weight loss. They are 34 years of age, and the doctor doesn't know because of what we know about the increasing incidence of colorectal cancer in the younger people. They're now recommending that the fecal occult blood test be done earlier than age 50, 55. However, the presence of fecal of occult blood in the feces, even though it has a high specificity, 90 to 95, it's not the gold standard for diagnosing colorectal cancer. The gold standard is still colonoscopy. More recently, there has been an upgrade on this test. It's now called Cologuard Plus. They're not looking for fecal occult blood. They're looking for genetic material that is being shed by the ever growing, expanding um, colon cancer. It has a very high sensitivity, 95%, equally high specificity, 94, but once again, you are going to need to do the colonoscopy, take a piece of the lesion, send it off to the histopathologist because that's the gold standard for diagnosing colorectal carcinoma. The other situation in which stool tests are ordered is when the patient comes and complains, usually mothers about their children. They saw worms in Isabella's stool. And then the physician will order a ova and parasite test of the stool. We're going to look at the ova, the egg, and then we're going to look at the parasites separately. And then we're going to have one composite slide that puts all of these together. So ova, uh, one of the more common worms in America is roundworms. The proper name for roundworms is Ascaris lumbricoides. Don't expect a question in part 2 or part 3 as to which is the most common roundworm or parasite in America vis-a-vis the world, etc. They're not interested in your remembering that kind of details in microbiology, but they need to for you to remember the description of the various eggs of the major ones, and I'm only going to use 4 kinds of parasites here. So Ascaris lumbricoides, otherwise known as roundworms, the classic description of the egg of the parasite, it has 2 walls, so double wall with the larva inside the innermost wall. Pinworms, otherwise known as threadworms, the proper name is Enterobius vermicularis. This is classic, the description. It is not oval. Oval is egg shape uniformly. Elongated egg. No, this is an elongated egg with one side flattened. Hence the term ovoid. Remember the suffix oid tells you it looks like, but it's not. So ovoid actually means it looks like an oval, but it's not. So anytime they describe the egg as being ovoid with one side flattened, that's the classic description of Enterobius vermicularis. The third is whipworm, otherwise known as Trichuris tricura. The classic description here is barrel shape with bipolar plugs. The 2 ends of the barrel have these plugs. Think of it as a wine barrel with the ends corked up to keep the wine from flowing out. This is classic for Tricura uh, infection. And then the last of the four I would be concentrating on would be tapeworms, whether it be Taenia solium or saginatum. The description here is a thick spherical wall, so it's round. The wall is thick, and they are radial striations through the thick wall. And this is what differentiates the egg, the ova of Taenia solium or saginatum from the eggs of Ascaris lumbricoides. So here is the composite picture for you to bear in mind. Double wall, Ascaris ovoid, shaped with one side flattened pinworms, bipolar barrel-shaped whipworms, and the thick spherical wall with radiations in the cell wall. If we were to look at the four parasites, this is what they're going to look like. Roundworms. They are approximately 6 to 8 inches in length, slightly smaller than the earthworms that are found in the garden. Sometimes you can have an abundance of these worms living in the bowel. I've actually assisted in a surgical operation where a young child presented with intestinal obstruction. There was a blockage, and when we opened the abdomen, there was this young round 4-inch ball in the small bowel. And as you were observing the ball, there were movements in various parts of the bowel. You opened it and you scooped out half a pound of roundworms. This is what your threadworm or pinworms look like. They have a hook on one side and a narrowed part to the tail end. This is what your whipworm looks like. It looks as if there's a handle. The thicker, blacker part is the handle, and the thinner part that is about 3 or 4 times longer than the handle. This is classic of whipworm or Trichuris tricura. And this is what your tapeworms look like, Taenia solium or Taenia saginata, segmented, flattened worms. There are about 4 other worms. The details are found in the reference textbooks or in my green book, the Chiro Essentials Differential Diagnosis, the most latest edition. I didn't want to bombard you with all of them because I'm preparing you for your boards, and here's the big 4 that they tend to ask students. And here's the composite picture of both the ova and the parasite. The parasite is in the small sphere off to the top left in each of the segments, and the one in the middle is what the eggs actually look like. There is one other stool test, and that stool test is called the tape test or the Scotch tape test. In this particular test, a strip of clear 3M Scotch tape is put in place in the perineal region of the patient just before they go to sleep at night. You leave it there overnight. Tomorrow, you remove this in the morning before the child gets out of bed, and then you press the sticky tape directly onto a glass slide and then look under the microscope, and you can actually see these worms with a hook curved part up at the head, and then the distal end is narrowed for a short segment, and this is classic for identifying your pinworms. Any questions? Okay, now we have about a dozen tests that are grouped under the miscellaneous tests. They're again arranged in alphabetical order. The first is a test of the serum. This is not an serological test because they're not testing for antibodies. They're testing for a particular protein chemical. The protein chemical is called alpha fetoprotein. Alpha fetoprotein in the blood of a pregnant mother uh, indicates the possibility of a child being born with spina bifida. And it's a screening tool. And if the alpha fetoprotein test is elevated, they're going to do a diagnostic ultrasound looking specifically on the spine of the fetus, looking to see if there is any abnormality suggestive of spina bifida. The technology in fetal surgery is so advanced these days that one, with the diagnostic tools we have, they can identify this early, go inside the mother's womb, repair that defect in the lumbar region, and then when the baby is born, not only is there no evidence of spina bifida, but there's no evidence of that there was surgery in the area. In the adult, if the alpha fetoprotein, which is a tumor marker, is used, it's indicative of hepatocellular carcinoma. Amylase, serum amylase, or lipase is used to indicate that the patient's epigastric pain that follows an alcoholic binge is actually due to pancreatitis. Both of them are equally sensitive and specific. One has a slightly higher sensitivity. We're talking about 94% versus 96, and the other one has a slightly higher specificity, 96 versus 94. Um, Lipase is the one that is a little more sensitive. Boards is looking forward for you to remember just serum amylase. Bence-Jones proteins. We've talked about Bence-Jones proteins a number of times in this trimester so far. Bence-Jones proteins are indicative, when you find this, of multiple myeloma. It's not the only cause of Bence-Jones proteins. There's another rarer condition that affects a different immunoglobulin in multiple myeloma. The immunoglobulin that is produced in excess is IgG, causing the M spike on a serum electrophoresis, which is used for diagnostic purposes for multiple myeloma. This, as I've said umpteen times before, is not tested for in your routine urinalysis. You have to request this particular test separately. And what they do with this particular test is they put this through electrophoresis. But since you're not using serum, you're using urine, it is now called urine electrophoresis. It's the same. You're looking for a particular type of light chain protein that will be precipitated when you do the electrophoresis. This was not the original technique that was used by Dr. Bence-Jones when it was first discovered. Dr. Bence-Jones was working in the lab many, many years ago. He was in charge of testing the urine for proteins, and in those days we had no reagents or dipstick. This is back in the 1950s. And the way they would test for proteins in general was put 5 cc's of urine in a test tube, gently heat the test tube with a Bunsen burner, and when the urine temperature gets hotter and hotter at around 60 degrees centigrade, the urine would suddenly become cloudy because you've coagulated the proteins, and you will go, yep, proteins is present. You put the tube down next to the other tubes that you've been testing, and you come back and you go, specimen A belonged to this patient, no protein. Specimen B, no protein. Specimen C was proteins. And you remember that the last specimen you had just tested was positive for proteins, and you come here, patient number 12, and you're about to write proteins positive. You look at the test tube in the test tube rack, and it looks absolutely clean. You go, wait a minute, I just tested this and it showed positive for proteins. What the hell is going on? You take the test tube with the urine, you redo the test, and again, 60 to 80 degrees centigrade, just before boiling point, it gets cloudy. And then you put it back, and once it cools down below 60 degrees centigrade, the cloudiness disappears. And then Bence-Jones went back into the patient's history and realized, this patient has been recently diagnosed with multiple myeloma. This is a strange phenomenon. Wrote this up, published this in a paper, got his name attached to this, and Bence-Jones proteins is linked now with multiple myeloma. Cortisol. Remember I said to you cortisol had a diurnal variation. It's high in the morning, low in the evening, comes back high in the morning. If you suspected that the patient has Cushing's syndrome, the lab is going to suggest the patient comes in at 10 o'clock in the evening. The urine is going to, not the urine, the blood is going to be collected because you're expecting cortisol to be at its lowest at 10, 11 o'clock at night. If the blood test shows that there are 12 nanograms per deciliter or milliliter of cortisol when it should be less than 2, then the lab report is going to say cortisol is high. If he were to come in at 8 o'clock in the morning and he gets a lab result of 8 nanograms per millimeter, the lab is going to say inconclusive because it's usually high at this time in the morning. Similarly, if you suspect Addison's disease, you don't want to be testing the blood at 10, 11 o'clock at night. You want to be testing the blood for your serum cortisol. It should be high at around 8, 9 o'clock. And if this patient has Addison's disease, it is going to be lower than 3 nanograms per milliliter. Okay, so please remember that because of the variation in cortisol levels due to the time. Any questions? We're not done as yet. I'm just giving you a breathing spot. Remember, anytime you've had enough, shut this down or put pause, you come back. All right, let's continue. The next in the group of miscellaneous tests is C-reactive protein. This is a special protein that the body produces when there is inflammation. It doesn't specify where the inflammation is coming from. It just says you have some inflammatory process going on in your body, and we're going to just confirm this. This test could be used in patients with rheumatoid arthritis who are being treated in some way or shape, and you want documentation that your treatment, whether it be low force chiropractic adjustment, whether it be physical therapy, whether it be herbal supplements of devil's claw or curcumin or some other naturally occurring anti-inflammatory agent, and you want to prove that the patient is getting better, you repeat the CRP, the C-reactive protein, and the value should be closer to normal. As I said, it's a non-specific test along with the erythrocyte sedimentation rate. However, There is has been an advance in the last decade of testing for HS CRP. HS, small letters, HS just simply means highly specific. And if you were to test specifically for HS C-reactive protein, you will find that these patients are likely to have high risks for developing cardiovascular diseases. And so it's being used as part of the evaluation to tell what's your risk score for developing cardiovascular diseases. This is a test that uses antibodies to bind onto the protein and then precipitate out the protein. It will cause cloudiness, and therefore this is a precipitation or an agglutination, precipitation test. Agglutination is different. The degree of turbidity, aka cloudiness, is a measure using light absorbance. As I said, the HS-CRP is highly sensitive for estimating cardiovascular risk. As I said just now, it's a similar test but a different technique to ESR, erythrocyte sedimentation rate. You have a particular kind of tube and you put some blood in these long capillary tubes, and you come back in an hour's time and you see the rate of how the blood separates out. You fill the tube to the top, and then in an hour's time, the cellular portion of the blood will separate out to the bottom, giving you this dark red, and the clear bit at the top, that's your serum. And then you measure this according to this scale here. So it's a marker for inflammation. Certain cancers, like breast cancer, like colorectal cancer, lymphomas, leukemias, renal cell cancer, prostatic carcinoma, are known to cause an elevation in your sedimentation rate. So it's not only just a marker for inflammation, it's a marker for certain cancers. The name of the test tubes is called wintergreen, and you document the speed at which the blood separates out into serum up at the top, cellular matter down at the bottom, and you report this as 20 millimeters in 1 hour, or 40 or 50 millimeters in 1 hour, or 10 millimeters in 1 hour. The higher the speed is, it's the greater is the erythrocyte sedimentation rate, and it's greater indication of the degree of inflammation. Then there's the D-xylose absorption test. The D-xylose absorption test is used as a screening test for celiac disease. You have the patient fast then overnight. You bring them in the morning, you do a baseline urine sample looking for D-xylose. So let me back up a little bit. D-xylose, obviously you know that this is a sugar. It is not glucose, it is not fructose, it's not galactose, it is xylose. Fortunately or unfortunately, there is no metabolic pathway that deals with D-xylose if it gets into the system. And we're going to use that as a measure. So we're going to ask the patient, we're going to check the urine, we can check the blood too. We're going to give them 25 grams of D-xylose to drink in a glass of water. And then we're going to test the urine. There's an equivalent blood test every hour for the next 5 hours, and we're looking specifically for D-xylose. If D-xylose is going to be absorbed with no problem, it gets into the blood. It goes around, finds no metabolic pathway in any tissue in the body, including the liver, and passes out unchanged in the urine up until 5 hours after. And you're going to test for this particular sugar. Now, if there was a problem with the absorption of these xylose, so you have a malabsorption problem, then your D-xylose excreted in the urine is going to be markedly reduced. Now, there are two scenarios that are likely to be investigated. This is when you have a patient presenting with steatorrhea. Now, remember what steatorrhea means? Steato, fat, rhea, to do with discharge. Steatorrhea means that your stool is filled with fat, and therefore the following F's are going to be associated with the description of steatorrhea. Steatorrhea is defined as the passage of fatty, floating, foul-smelling feces. Let's do that again. Fatty, floating, foul-smelling feces. It's fatty because the body is lacking the ability to either digest fat or absorb fat. It is floating because oil is going to, lift it up, make it lighter, not heavier. It is going to be foul smelling because the fat is going to then undergo rancid degeneration, and that is going to be in the feces. Now, there are two causes of steatorrhea: fatty, floating, foul-smelling feces. One is malabsorption, where the absorptive surface where fat is going to be absorbed, which is the small bowel, is markedly decreased, or maldigestion. And in maldigestion, which is usually associated with chronic pancreatitis, the pancreas is no longer producing enough pancreatic lipase. The fat stays undigested in the feces and then presents with steatorrhea. Two different pathophysiologies for the same clinical feature. Now, D-xylose absorption is going to be normal in maldigestion associated with chronic pancreatitis, but will be decreased in malabsorption associated primarily with celiac disease. And we'll do celiac disease later on in the curriculum when we do fatigue associated with various other complaints. Next is serum ferritin. Ferritin is the form in which iron is stored in the body. If your serum ferritin is low, you can confirm the diagnosis of iron deficiency. If serum ferritin is high, it supports the diagnosis of hereditary hemochromatosis, which will be confirmed by doing a genetic test to prove that you have a particular gene dysfunction that results in this familial condition. Transferrin and total iron binding capacity. I know F isn't followed by T, so bear with me. The reason I'm bringing this up right now is that I want to finish the discussion on what particular tests do you use to confirm the diagnosis of iron deficiency. Serum ferritin to confirm, but the other two tests that boards are going to ask you about is your total iron binding capacity and your transferrin. Transferrin is an intermediate compound that when your iron is absorbed through the duodenum and the upper part of the jejunum, it is then converted to transferrin, which then takes it from the gut wall side to the blood side, dumps it into the tributaries of the portal vein, is taken to the liver, and that transferrin is now then changed into ferritin, and that is how the iron is stored. So For both transferrin and total iron binding capacity, they're going to have an opposite value for iron deficiency versus hemochromatosis. In hereditary hemochromatosis, transferrin is going to be low, and your total iron binding capacity will be also low in hereditary hemochromatosis, which results in iron overload. If this patient suffers from iron deficiency, then your transferrin is going to be high and your total iron binding capacity is going to be low. Remember, ferritin goes in the opposite direction of your total iron binding capacity and transferrin. Back to following the alphabetical order. FEV. FEV stands for force expiratory volume pushed out in 1 second. This is part of the spirometry examination for lung volumes in a patient with emphysema, asthma, chronic bronchitis, bronchiectasis, sarcoidosis, and any diseases likely to affect the capacity of the lung to expand and contract. And it is the amount of air that so you breathe normally, that's the tidal volume at around 350. And then you're going to take a deep breath out. And then you're going to inhale, and that goes up to nearly 1 liter. And then in that time, you are going to force out from your lung as fast as you can. So let's go normal breath, in, out, in, out. Take a deep breath in, force as much of it out. And they will measure in that first second of forced expiration how much air you're breathing out. The normal is above 80%. If it is less than 70%, it is diagnostic of asthma. You have a obstructive airway disease problem. Any questions? Continuing, hair analysis. Hair analysis has been used for all kinds of things, whether it's traditional or not traditional, but as far as the boards is concerned, it is only you're going to be tested on the use of hair analysis to prove that somebody has attempted to poison a patient with heavy metal, either lead or arsenic. It could also be used by some nutritionists for nutritional assessment. Are you lacking a certain level of a micronutrient like selenium, etc.? And they would test the hair and come back and tell you 3 weeks later that you're lacking these 4 different nutrients that are vital to your body, and they have a customized supplement plan, and they will give you some insight as to what kinds of the diseases you're likely to have based on their detection of mineral imbalances. That's on the left-hand column of the diagram. Basically, you're looking here at looking for toxic element identification, and if you identify that this is arsenical poisoning or lead poisoning after they do their detoxification, chelation, to get rid of some of these heavy metals, then they're going to want to retest again. And also for forensic purposes, this is also useful. They can tell you, oh, your husband has actually been trying to poison you for the last 5 years, giving you little bits of arsenic in your favorite tea every evening, and you've built up and you don't feel the evidence of the toxicity until it's too late. So heavy metal poisoning, and you can also use hair analysis legitimately to test manganese levels in the body or zinc. And as I said, some physicians or nutritionists would use this as part of their nutritional assessment. Continuing, homocysteine. We talked about homocysteine before. Homocysteine is elevated in both folic acid deficiency and vitamin B12 deficiency. If you want, so doing a homocysteine test is not going to tell you, oh, this is folic acid or B12 deficiency. You actually have to do both. If you added the methylmalonic acid is only elevated in B12 deficiency. As I said, this is of historical significance. Boards are still stuck in the past. Today, you send this to a special lab that does a bioassay of B9 and B12, and you get a result a week later to tell you what exactly is deficient and how deficient. Next in the alphabetical order is osmotic fragility. We talked about this as a test that is used if you suspect a patient having hereditary spherocytosis. In hereditary spherocytosis, the disease is genetically inherited. The cells, the red blood cells, instead of being donut-shaped by concave discs, it's round like a mini golf ball, which then prematurely allows the red blood cells to rupture. There's a lack of spectrin in the cell wall, which makes it rigid and more fragile to rupture. And what you do is you have test tubes of different concentrations of sodium salt in water dropped into a series of test tubes with decreasing concentration of saline, sodium chloride. You start off with normal saline, that's for the blood, 0.85%, and then you dilute this until you get almost water, which is 0.1. Water would be 0% of sodium chloride. Normal blood lyses at around the 0.3 solution. So picture on the left, there's the inoculated tube with the concentration of the solution there. You drop 1 drop of blood. The blood is now unclotted. And what would happen is that 1 drop of blood would drop slowly from the top down to the bottom, and you find the streak of blood. That's a negative test. And if when you drop the blood into the test tube on contact with the low sodium chloride concentration, it ruptures and uniformly colors the test tube, then that would be considered a positive osmotic fragility test. The hereditary spherocytosis, the red blood cells start to lyse at a much higher concentration than normal blood, which lyses at around 0.3. And therefore, early up in the test tube, there's about a dozen test tubes in sequence from high concentration to low concentration. Any questions? We're near to the end, so hang on and be patient. Other tests, miscellaneous tests, include the prostatic or prostate-specific antigen. This is a protein that is secreted only in men and only by the prostate. It is a screening test for prostate cancer if the result of your PSA is above 10 picograms per deciliter. The normal is between 0 and 4. If it is at 4.5 or 5.6, may not be indicative of prostate cancer, but it could be of other causes of an elevated PSA, which would include benign prostatic hyperplasia, digital rectal examination within the last 2 weeks, post-ejaculation within the last week of having sex, your PSA is elevated. So the timing of this needs to be correct. because you don't want to claim that, I'm sending you off to the urologist because I think you have cancer when you don't have cancer. Other tests include skin tests like the Mantoux skin test, which is a test for TB. In this particular test, you are going to inject into the skin. This is an intradermal, not subcutaneous injection into the skin of a compound known as purified protein derivative, PPD. This purified protein derivative is derived from the thick cell wall that is characteristic of Mycobacterium tuberculosis. It's a protein material, has the ability to induce uh, antibody reaction, and therefore this is an antibody reaction test. We are not testing the serum, therefore this is not a serological test. After injecting the PPD into the skin, and it's a small amount, you have the patient come back 48 hours or 72 hours later and you read this. And what you are reading is the firmness, not the redness, the firmness of the injection site. This is called induration. The word induration means firm or hard. And if it is more than 15 millimeters or 50 millimeters or more, then your Mantoux skin test for TB is positive. It means a number of things. You could have been born in developing countries where it was mandatory for all children to be given the BCG vaccine, which has the same proteins that are contained in the purified protein derivative, and therefore the body would have been exposed to this antigen as a child. You already have preformed antibodies. Or you've had TB in the past, it is now gone completely, whether you recognize this or whether you had treatment, or you have current tuberculosis present. There's a much better test. It's called the quantiferon TB Gold test. This is a blood test where you look specifically for a chemical known as interferon. Interferon is a number of specific cytokines that are produced when the body's immune system is invaded. These are kinins, messengers that are produced by the T cells. Blood is collected in a special tube. It is incubated for 24 hours. It is read after that 24-hour period. And if your quantiferon TB Gold test is positive, then you have either active TB or latent TB. And I know you've done this with Dr. Bodalia, and Dr. Bodalia teaches that the quantiferon TB test is the gold standard. That may be so, but if you want the truth, and I've encouraged Dr. Bodalia to check his reference as to where he's getting his information. I'm getting my information out from the Centers for Disease Control and Prevention, CDC. According to their most recent guidelines published online, the diagnosis of TB, the gold standard, and this is the CDC guidelines, is culture. You either use the Lowenstein-Jensen culture, which is unfortunately going to take 6 weeks to come back positive or negative, or more recently there's been a faster culture medium known as the Middlebrook. You can get a positive result in 3 weeks. Also, you could use the stain. If you have enough sputum that the patient coughs up and you send it to the lab and they stain it with the standard Zeal-Nielsen stain and they find positive AAFB. AAFB stands for acid alcohol fast bacilli, which is another way of saying Mycobacterium tuberculosis, you have the diagnosis of for TB. Because why am I making such a big thing about this? TB is a serious condition worldwide. In fact, TB has killed more people over the last 200 years than the recent pandemic with COVID-19. And although we have the capacity to treat this worldwide, unfortunately for us, um, many of the TB bacilli have developed resistance to the drugs we actually have at our in our armamentaria. You are committing a patient to 6 months at least of supervised therapy. You're going to be brought into the clinic on a particular day every month, no, every day for the next 6 months, and you're given three different drugs or four different drugs depending on the multi-drug protocol that the Department of Health uses, and they want to see you drink those tablets and then see you back tomorrow. And the reason for them doing this is that they don't want you to not take your tablets, because sometimes the isoniazid might upset people's stomach. The rifampicin may cause their urine to go bright orange, and you go, yeah, don't want to take this crap. I'm going to get my atlas adjusted, and my init is going to take care of my TB. Be that as it may, I'm not knocking chiropractic. Um, they are trying to avoid what is known as multi-drug resistance. In fact, there are a couple of strains of not multi-drug resistance, extreme drug resistance TB bacilli in America. They're now investigating the recent outbreak of tuberculosis in Kansas, and it's associated with a lot of multi-drug resistant strains. Not yet found an extreme where none of the drugs, the 12 drugs that we have available to treat TB, are working. And then there is the urease breath test. Urease is an enzyme that is produced by Helicobacter pylori and Proteus mirabilis. If you have Helicobacter pylori that causes peptic ulcers, you can use this non-invasive test, because the gold standard for peptic ulcer disease is doing an endoscopy, finding the ulcer, biopsying the ulcer, and then growing from there, identifying Helicobacter pylori. 75% of all gastric peptic ulcers are caused by H. pylori. 95% of all duodenal ulcers are caused by H. pylori, which is, as I said, gram-negative urease-positive bacillus. What they actually do in the lab is create a special form of urea. Remember, urea is the combination of ammonia plus carbon dioxide. The carbon dioxide that they're going to add on to the ammonia in the lab is carrying a carbon label 14, and that radiocarbon 14 going into the CO2 is then going to be picked up eventually with a breath analysis. You swallow this concoction of urea with the carbon 14 carbon dioxide, and when it gets into the stomach, if there is H. pylori, the urease produced by H. pylori is going to break down the urea into ammonia and your carbon dated or labeled, not carbon dated, carbon labeled CO2. And what happens, there's a special breathalyzer. You breathe into this sometime afterwards, and that CO2 is going to be expelled into the air, into this particular apparatus, which is like a mini Geiger counter, and it will tick, tick, tick. Yes, there is this radiocarbon inside the breath, and you have the best non-invasive test for peptic ulcer by doing the urease breath test. And then finally, we're going to look at vanillyl mandelic acid. Vanillyl mandelic acid is a byproduct of the breakdown of norepinephrine. Norepinephrine comes in excess in pheochromocytoma. Remember, this is the 10% tumor because 10% is bilateral, 10% are malignant, 10% runs in the family. And when you break down norepinephrine, so look at the diagram, norepinephrine could go into two ways. It could go to the right, broken down by an enzyme known as COMT, cathecol O-methyltransferase, to normetanephrine, and then coming down straight on the right, being acted on by a different enzyme known as monoamine oxidase, and you have vanillyl mandelic acid, a non-active metabolite that is excreted in the urine. You know that norepinephrine can be converted to epinephrine out in the periphery. Epinephrine can go both ways, converted to metanephrine by COMT, or it could be broken down by MAO, monoamine oxidase, into dihydroxymandelic acid, and that dihydroxymandelic acid is then going to be converted by cathecol O-methyltransferase into VMA, which is vanillyl mandelic acid. So when VMA is present in the urine, not only should you be thinking of the possibility of pheochromocytoma as the cause of the episodes of hypertension, but you should remember that this is a metabolite of the breakdown of norepinephrine in the urine. Any questions? I have a few sample multiple choice questions to prepare you to give you an example. There are much more samples in Brightspace under the quizzes that are related to this subject. So here's the first standard part 2 question. A 10-year-old child's stool is examined. Ovoid eggs were discovered. Which of the following intestinal parasites is most likely to be responsible for this finding? You have 4 choices. Remember, the key word here is ovoid. It looks like an oval, but it's not oval. And the correct answer is Enterobius vermicularis. Remember, when you use these questions, you're not only looking for the correct answer, because none of the questions that are embedded in Brightspace you're going to get back verbatim. All I have to do is change one word or add something different, and I have a totally different answer. So I can put the same 10-year-old child's stool was examined and eggs with a double wall were found. Which of the following intestinal parasites? The question remains the same. The choices remain the same. And then you're going to choose double. Okay, this must be Ascaris lumbricoides. Another typical part 2 question. Numerous red blood cells and envelope-shaped crystals were found in the urine analysis of a patient with painful hematuria. Which stones are more likely to be responsible for these findings? And you got to remember envelope-shaped crystals, coffin-lid crystals, barrel-shaped crystals, or whatever was the other one, and you go envelope-shaped crystals is more likely to occur in patients with calcium oxalate stones. You need to know that triple phosphate stones are going to be characterized by your coffin lid. Your hexagonal shaped stones would be cystine, and your barrel shape or diamond shape crystals would be indicative of uric acid. Another good example A 78-year-old female patient complains of fatigue on examination. Her mucous membranes are pale. She has koilonychia. A complete blood count reveals a microcytic hyperchromic anemia, which would be the next appropriate step in investigating her problem. So you're looking at this and you're going, she's fatigued, she's anemic, and the anemia is iron deficient. What causes are likely to give you that picture? And then you choose which of the following four. Or if you don't want to go that route, you look at the four choices and you go down each of them and ask yourself, what is a guaiac stool test used for? A guaiac stool test is also known as a fecal occult blood test. It would be used for finding blood that is hidden in the stool. Could blood hidden in the stool be responsible for fatigue, anemia, and koilonychia? Possibility, because this could be very well the beginnings of colorectal cancer, which are more common in the elderly. So A is a possible answer. But remember, once you find the answer, don't turn the page or go to the next question. Go through the other choices because there may be a more correct choice facing you. Request a CT scan of the abdomen. Why? Well, I don't know. If you can't find a valid reason for requesting a CT scan of the abdomen, which is going to cost the patient some money. Now remember, we talked about the costs and implications in this series of lectures. Order a comprehensive metabolic panel. Okay. And I go through in my head changes in the urea, changes in the electrolytes, changes in the bilirubin, the total proteins, and you're struggling to find a reason as to why you're going to order that particular test, you go, okay, no. How about the last one? Recommend she takes iron supplements. Yeah. Iron deficiency is the most common cause of a microcytic anemia. It could have been lead poisoning. It could have been thalassemia. But I'm going to use the law of odds and gamble with this patient's life and say to her, you have an iron deficiency anemia. I'm not even going to bother test for your transferrin, your TIBC, or do a confirmatory test like ferritin. I'm going to say to you, take 3 tablets, 1 tablet of iron 3 times a day, come back and see me in a month's time, and we retest your blood. Wrong. This patient is a real patient. She was not 78 years of age. She was 81. Connie was 81. She was a church member when I came here 20 odd years ago. She collapsed in the car park after leaving service one Sunday. We examined her, found that she was severely anemic. She had koilonychia. I said to her husband, Dom, take the old girl to see her GP tomorrow. Came back 2 weeks later. Connie has stage 4 colorectal cancer. Too late. She died 3 months later. But she was happy to go. She was ready to meet her Lord and Savior. Had I prescribed, tell Dom go to the CVS pharmacy, pick up some iron tablets, she might have recovered a bit because replace the iron, she's going to get some energy, but it would do nothing to the underlying problem. So the answer to this question here is the guaiac stool test, otherwise known as the fecal occult blood test. Here's another classic part 2 multiple choice. In a fatigued patient with bilateral exophthalmos and tachycardia, which results are more likely to be associated with these findings? And this is a 2-step. To answer the question, you have to first make the diagnosis. What's the most likely cause of fatigue in a female patient with bilateral exophthalmos and tachycardia? The answer is, yep, Graves' disease, which of these is most likely to be positive? A, microcytic hyperchromic anemia? No. Macrocytic normochromic anemia? No. Raised T3, T4, and low TSH? Yeah. Decreased T3, T4, and raised TSH? No, because that would be myxedema. So C is the correct answer. Okay, here's another typical NBCE Part 2 multiple choice question. In a young black child with pale mucous membranes and blue gum line, which laboratory results are more likely to be present? A. Is it hyperbilirubinemia, raised alkaline phosphatase, and absent urobilinogen? B. Low red blood cell count, raised mean corpuscular volume, and normal mean corpuscular hemoglobin concentration? C. Low white blood cell count, normal red blood cell count, and hypercalcemia? Or is it D? Low hemoglobin, low mean corpuscular volume, and normal total iron binding capacity? Okay, so which of these is the correct answer? The correct answer is low hemoglobin, low mean corpuscular volume, and a normal iron binding capacity. Those findings in D are suggestive of an anemia that is microcytic in nature. So the anemia is implied by the low hemoglobin. The low mean corpuscular volume tells you this is a microcytic anemia. It could be either iron deficiency anemia or lead poisoning. Lead poisoning is more likely to be associated with blue gum lines, and normal total iron binding capacity is going to fit into that picture of a microcytic hyperchromic anemia caused by iron deficiency. How about this question? This is a typical extended multiple choice question in part 3. Which two statements are correct regarding a 67-year-old man with a hard and gerated prostate, elevated PSA, hypercalcemia, and a normal albumin globulin ratio? Well, older men, hard and gerated prostate, this is more likely to be prostate cancer as opposed to benign prostatic hyperplasia. Elevated PSA goes along with prostate cancer, so A is probably correct. Prostate cancer is the most likely diagnosis. If that is so, is conservative care with saw palmetto highly recommended? I don't think so. Saw palmetto has fallen out of favor in the last decade because longitudinal studies have shown that taking saw palmetto supplements does not prevent the occurrence of prostate cancer. C. He has hyperparathyroidism. Now, hyperparathyroidism is likely to be associated with hypercalcemia and the normal albumin globulin ratio, but not with a hard and gerated prostate and an elevated PSA. So C is out. He should be seen by an endocrinologist. If his problem were hyperparathyroidism, then yes, an endocrinologist would be most appropriate, but that is not the most likely diagnosis. The most likely diagnosis is prostate cancer, and therefore choice E, he should be referred to a urologist, is more likely to be correct. And that are the two answers to this particular kind of question. How about this part 3 question? Which two statements regarding a 37-year-old black female with progressive dyspnea, red bumps on her legs, leukopenia, and hypercalcemia? Now, I've said to you before, this is probably the third or fourth time I'm bringing this to your attention. The combination of leukopenia, a low white blood cell count, and hypercalcemia, high serum calcium, is indicative of sarcoidosis. So, yes, sarcoidosis is the most likely diagnosis. Let's see if B fits sarcoidosis. Is sarcoidosis best treated with conservative care and CBD oil? No. We actually don't know the cause of sarcoidosis, so some patients have said they have found a lot of relief of the shortness of breath with CBD oil, and the lumps on their skin may go away, but that is not the recommendation about the treatment of sarcoidosis. How about C? She has hyperparathyroidism. Yes, in hyperparathyroidism, you will get hypercalcemia, but you will not get progressive dyspnea and red bumps on the legs, which is the description of erythema nodosa. Erythema means red, nodosa means nodules. And hyperparathyroidism will not cause a decrease in the number of white blood cells in the blood. So, no, she does not have hyperparathyroidism. D. She should be seen by a dermatologist. Why? Well, maybe if you don't know what the cause of the dark red bumps on her leg, it may be acceptable for her to be seen by a dermatologist. Dermatologist is unlikely to make the connection between this and sarcoidosis, so the diagnosis might be delayed. And E. She should be referred to a pulmonologist. Why? Because of the progressive dyspnea? Yes. 90% of patients with sarcoidosis have pulmonary pathology. Many of them have on an x-ray the following radiological findings: bilateral hilar lymphadenopathy. So yes, she should be referred to a pulmonologist. All right, that concludes a lengthy 2 week discussion on the use of labs in diagnosis. We are going to be referring back to the majority of this presentation as we move forward for the next um, 10 weeks every time, and we'll be doing a complaint in the following weeks. One complaint per week, and every time we do a complaint, we'll be reviewing the lab results that are mentioned in the discussion about the diseases. So, in preparation for next week's work, which will be on EENTI, ear, nose, and throat problems, please read the relevant chapter in Chiro Essentials Differential Diagnosis. Download the appropriate keywords, read this before coming, and then bring them uh, to the lecture so that we can have an informed discussion. Okay, bye for now.